Greetings, everybody. Harshad, how you doing?
Hi, John. I'm fine. How are you?
Good. So you've been going to many webcasts?
Yes.
Good. But none as
Yes,
good as these, right?
yes, just attended Luis Borba, Cranial Pharyngioma,
Oh yeah,
then
he was in
heard,
Russia, right?
and then Professor Yasagil spoke just now, and
Isn't
now
it, isn't
looking
it wonderful?
wonderful, wonderful. Now just looking forward for to learn something more.
Okay, let me get off. Okay, I gotta get the right one here. Yeah, it's nice. It's nice to jump from one to the other, right?
We just finished that, and now thought you will be starting soon.
Yeah, they had four presentations from Russia.
Mhm. John, it's nice to be in USA for a short visit.
Where's that?
I'm in New York just now.
Oh, you're in Europe now?
Yeah, for a short visit. My son graduated yesterday
Oh
in New York.
wow, from where?
So yeah, he is in New York, Long Island,
Oh,
Stony
okay.
Brook
Is he
University.
is
Yeah.
he in medicine too?
No. He's doing finance and economics.
Oh, he's smart.
Yeah, smart. So I came to, attend that function. So for a week I'm here. It's nice weather here.
I'm sorry. What country did you say, Harshad?
I'm in New York, New York.
Oh, New York City.
Yeah, New York City, yeah, Long Island.
Oh wow. Oh man, that's a big city.
Yeah, I'm in Long Island, New Stony Brook University.
I always get lost when I go there.
Just here for a few days and then we'll go back to Mumbai.
Well, you
Weather
won't be
is super.
driving, right? You'll just be taking taxis and stuff.
Yeah.
So you don't have to know the city, but it's not easy.
Yes.
And that
Yeah,
the
so
freeways are so fast that if you
fast.
miss
Yeah.
a turnoff,
Yeah,
forget it. You're lost. It takes an hour to go around, go back,
gone. Yeah, yeah.
unless you know the exits. And sometimes they come up very quickly because you're
Mhm.
concentrating on not getting lost, and all of a
Yeah.
sudden the exit's
Mm.
going by. So you got a good Wi-Fi, huh, from your hotel?
Yeah, yeah. Good Wi-Fi and nice. I'm in hotel. We'll be moving to the Manhattan today. Mm.
Well, in Cuba, the Wi-Fi used to be really bad, but it's getting better. It's
Mhm.
still not really good, but I mean, it's so much better than like 3 or 4 years ago.
Mm.
In this country, it's rare you find a hotel that doesn't provide Wi-Fi. Most of
Yeah,
them provide it. It's part of the
yeah.
service. It's like water now.
It's a huge campus where I'm staying now. Huge, very huge
No,
in
what is that?
miles.
NYU?
No, it is not NYU. It is Long Island, and it is called Stony Brook University. It is a state university.
Oh, Sunnybrook?
Stony, Stony, Stony
Oh, yeah,
Brook.
Sony's. Yeah, okay. Okay.
Mm,
Yeah, it's a huge system in a couple of cities, I think, in New York.
yeah, yeah.
Oh. Oh, sure, I'll make you co-host also. Hey, Sam. Good morning, Sam. Hello, Sam. Can you hear me? Hello, Sam. Can you hear me?
Yes, it's okay.
Oh, okay. You can hear me. Can you speak, Sam? I don't hear you that good.
I am here. Is it okay?
Okay. Well, I don't know. To me, the sound is kind of low. Harshad, is this sound okay? Go ahead, Sam. Speak, please.
I am here. It's okay.
Yeah, Sam, can you, Harshad, does he sound muted to you? Maybe it's me. Maybe it's my ears.
Is it okay?
Are you recording this, Sam, also?
No, no.
Oh, someone is. Well, it doesn't really matter. It's going to be on the internet anyways.
Okay, okay. صح.
Oh, someone stop recording. It's okay if someone wants to record. It's because YouTube, Sam, YouTube will immediately recognize if you had a duplicate on the internet, and they'll come down hard. Those robots are very evil. So Sam, after every speaker, you're going to ask questions, you're going to wait to the end, or what are you going to do?
Yes, John. And first speaker will be Professor Sanford Histo.
Well, again, Sam, please.
Professor Sanford will be the first speaker.
Oh, okay, he's here now, right?
Yes.
Yeah, okay. The Sabea. Yeah, don't be afraid to let someone in there, Sam, because you can admit people. You know how to do that, right? Good morning, Dr. Sabea. Can your audio is not working, Dr. Sabea.
You are muted.
Hello.
Yeah,
John.
there we go. There we go.
Right. Nice to see you.
Nice to see you. Welcome. Oh, so Charlie's not first, Sam?
No, Charlie will be at the end. We
Oh,
will
okay,
start with Professor Sanford.
okay, so it's different than the schedule,
Yep,
huh? Okay.
I will update you. Okay, John, 2 minutes to start.
Okay, Sam, let's see, I have actually 3 minutes. It's
Okay.
9:57 here. Is it different there? You're jumping the gun, Sam.
Okay,
Just a second, okay?
okay.
We got 2 minutes, Sam. So Sanford second, then Chandra, then Atul, right?
Yes,
And then Ibrahim.
yes.
Okay, Sam, you want to jump the gun, right?
Yep.
Okay, you ready, Sam? Okay, Sam. 10, 9, 8. Oh, so what? Someone was recording before. Okay. Oh, okay. Let me stop. Hold on. Okay, we'll try it again. Okay. 10, 9, 8. Good morning from Miami Beach, Florida. This is Dr. John Bennett of Neurosurgical TV. I'm glad to be with Sam L. Morsi of the EWNC again with his most recent webcast, Most Remarkable Lessons from the OR. I'll turn it over immediately to Samuel. Good morning, Sam.
Good morning, John. Thank you, dear professors and friends, for accepting our invitation for this unexperienced webinar. Today, we will learn another thing that we never experienced before. It's about most remarkable lessons from OR. And we will start our journey by Professor Sanford. Professor Sanford, please start sharing your screen. Thank you.
Thank you, Sam, and thank you, everyone. Good to see my screen now.
It's okay.
Yeah, and did you hear my voice?
Loud
Yes.
and clear.
Yes. Today, I'm very glad to be invited to give a talk at this webinar. And they asked me about the remarkable lessons from the OR. So I'm thinking of some glioma surgery around so-called eloquent area. And actually, sorry. So I have done the fellowship at UMass in Little Rocks between 2007 and 9. And at that time, it's the mecca of microneurosurgery because we had Professor Yazago and Professor Marty and Ali Krisht. And actually, today I talk about the glioma surgery. I learned a lot of the microneurosurgical concepts from Professor Yazago. And the slide shows is the first visit, when his first visit to Taipei in 2006. And I made it slides for him. And actually his principle or concept of microneurosurgery is highlighted in these slides. He always using the cisternal anatomy and so-called the cisternal navigation to the targets. And also his concept of the brain is based from the embryology theories. And so we had a lot of the different compartmental anatomy relating to the lesions. For example, is arising from neocortex or from the limbic paralimbic system. And also he tried his best to completely eliminate the lesion. And although he invented the retraction system, but he rarely using the rigid retraction. He just keep the brain in place. So this is the basic of his microneurosurgical concepts. Simply to say, using actually is real minimal invasive techniques using the cystone navigation, retractalis techniques to totally remove the tumor based on these compartment concepts and some coagulation or the hemostasis techniques. And two most important anatomy bases of Professor microneurosurgery, like I said, is compartment concept, and also one of the most important one is one meta tracks techniques, what you learned from the Professor Klingler, the session. So as I mentioned, you always mention we have different systems within the brain, including the neocortex, mesocortex, and allocortex, forming the neopaleo system. So why we have to learn the glioma surgery based on the embryologic knowledge? Because the compartment concept developed from the embryologic basis with the different tumor growth pattern in specific compartments. So later I will show some cases. And also the surgical approach is one of minimally invasive to the lesion in some specific compartment. And then we have to try to avoid disturbing or destroying the innocent fibers. So this is the growth tumor behavior. The tumor growth pattern is different from the limbic and paralimbic system. It's the neocortex lesions. So maybe it's rising from one gyro or maybe involving two or more compartments, but they always point to the ventricular system. So like his surgical photos shows, before the surgery and after the surgery, and you can see he just precisely removed the tumor and leave the normal tissue intact. And all the recession actually is pointing to the ventricle. So we have to familiar with the anatomies of the gyri and the sulci. It is very important to remove the tumor, such like the neocortex glioma. And also another system is the limbic and paralimbic system. For example, the insular tumors, hippocampal tumors, frontal orbital tumors, or cingulate tumors. And the growth pattern is quite different from the neocortex. The tumor is always that's growing always within the similar system. For example, in this case, initially the tumor is arising from the insula. And when you remove the tumor, 2 years later, the tumor recurred, but it's recurred in the temporal pole. Why it is recur in the temporal pole, but not in the T2, T3? Because the temporal pole is in the same system as in the insula. They all belong to the limbic and paralimbic system. So the tumor, such kind of tumor, they are always growing in the same system, different from the neocortex tumor. Sometimes it's very difficult to delineate the origin of the tumor, such in this case. But when you precisely remove the tumor along its tumor margin, then you can realize, oh, it is from the hippocampus, just surrounding the basal ganglion and upward to almost to the cingulate. So Professor choose the best approach to the glioma, like we did the skull-based surgery, and he always based on the anatomy and also based on the fibers, what he learned from the Professor Klingler. In this paper, the Professor Nick Cranville, he described which the best way, the best approach to the messiotemporal region. and he analyzed that in the supracellular transdendron approach, actually the minimal amount of the fibers are destroyed. So this is the best approach to mesiotemporal region based on the concept of the fibers, because in this approach, the damage, the number of the fiber damage is minimal. So this is a so-called minimal invasive surgery to the glioma. So in his book, you can find he developed several approach. He always using a system, the natural corridor to the deep-seated lesion. And also he choose the best way, depends on the number of the fibers that should be destroyed. But the most frequently asked question is about if maximal recession is equals to the maximal mobility. So one day I asked Professor, how did you do with the so-called eloquent area tumor? And he said he never saw any glioma arising from the so-called eloquent area, or like a motor area or language area. But at that time, I adopted because most of the surgeons said, oh, the tumor is arising from the motor cortex and is inoperable. So like my teacher, when I visited Little Rock before in my institute, some of my teachers also say, oh, this cannot be operated because it's arising from the motor cortex or from the Wernicke area. You will cause a lot of the mobility to the patients. So when I back to Taipei, I did my surgery, but I still follow the principle of the professor. So such a case, the tumor is actually arising from the premotor area, supplementary motor area. So such cases always delineate the tumor margin. And of course, I would do the intraoperative mapping and monitoring, and I will delineate the precentral gyrus. And since I decide the precentral gyrus, then I will remove the tumor totally along the tumor margin. But in this case, in such case, most of the patient developed supplementary SMA syndrome. Right after the surgery, as you can see, the patient cannot lift his hand. So 1 month later, he can already mobilize to move his joints, and also you can do some grasping 1 month later. And actually, as you can see, after the surgery, the thread is intact. So you can see 10 years later, and the patient sent his video. The patient is actually totally neurologically intact. So for me, such a kind of lesion is not the tumor, it's not the eloquent area tumor. It's just the patient will suffer the transient deficit, but you nearly or totally recovered around 1 month. This is so-called SMA syndrome. So this is not a real, as you can see, it is not a real eloquent area tumor. You can totally remove such kind of lesion. But how about this case? I did a lot of the premotor area tumor, but this is the first case I met in the OR. And when I look carefully into the pictures, I'm thinking, oh, this tumor is really arising from the motor cortex. This, as you can see, and this is the premotor gyrus, precentral gyrus, this is postcentral gyrus. And this should be the precentral gyrus, and this is postcentral gyrus. And I open the brain, and I do the intraoperating mapping, and I really evoke the motor response in this area. So I define this area as the precentral gyrus. So I'm thinking, oh, maybe this is maybe professor's wrong. The glioma is really arising from the motor gyrus. So in this case, I just do a small recession, small wedge recession in the premotor region, and I leave the tumor in the so-called the motor and or the sensory gyrus, the precentral or postcentral gyrus. This is case, I think is 2014. So I did only partial recession. And at that time, the tumor turns out the oligoastrocytoma. But in this year, in February, the patient kept regular follow-up on the clinic, and I realized the tumor is growing. So as you can see, this defect is the previous operated tumor bed, and the tumor is growing, enlarging, and then the DW, you can see the high signal. So in my mind, the tumor is recurring, but and also maybe had a malignant transformation. So I need to do something. But this time I did the tractogram. So as you can see, the real corticospinal tract color in blue is pushed by the tumor. The tumor is in color in green, and is actually bounding by these two drainage veins. So this time I also open it, and I remove the lesion between, as you can see, this drainage vein is this one, and this drainage vein is this one. So I remove the tumor along this margin, and I also using the intra-opt subcortical mapping, so I can evoke the motor response at this corner. So I remove the tumor along this margin and do the maximal recession as I can do. And as you can see, I remove the most part of the tumor. So this time, I try my best to remove most part of the tumor, and it turns out to be the anaplastic oligodendroglioma. But it's amazing to me that the patient is doing good. The patient even didn't develop the SMA syndrome. He's even better than before. So in this case, I got impressed that Professor Yasago is right. Tumor never arising from the real motor gyrus, the so-called precentral gyrus. They just push the fiber away. So if you did a good study before the surgery and you look carefully about the tracks, if you can do the tumor recession precisely along the tumor margin, then actually the patient would benefit a lot from the surgery and keep the neurologically intact. Also, this case, most of the case, people will say, oh, the tumor is rising from the speech area. This is Broca area. And most of the people will do the awake craniotomy, like this case. Yes, I did the awake craniotomy, and I do some language mapping, and I realized that this gyrus lesion and all the functional response surrounding the tumor margin. So this case is very simple. I just remove this gyrus along the tumor margin. And right after the surgery, actually the patient is performing very well. He didn't have any language deficits. But in this case, it's a very large tumor, also in the so-called Broca area. And the patient already had a naming problem, a speech problem, and also the seizure attack. In this case, we didn't do the awake craniotomy. With two-stage study, we put the grid at one stage, and we did the careful mapping and study of the seizure ictal area. And at the stage 2, we do the tumor recession. But this is the result, what we are mapping. As you can see, the tumor margin is along the frontal operculum. This is the tumor. This is very big. This is the tumor. But we also found that some of the language functional area is overlapping with the tumor gyrus, the tumor area. So in this case, what we would do? I believed in professor. He told me that the tumor never rise in the eloquent area, but why you get such a mapping result? It seems that all the functional evoked from the tumor area. But in this case, I don't believe the result of mapping. I totally remove the tumor along this margin, like you can see in the picture. I totally remove the tumor. And this is suppose a picture. And right after the surgery, the day one, he can answer his name. He can answer his address of his home. So you can see the difficulty to speaking. But at the day 3, he can speak out his address of the house. And 8 months later, when he visited my clinic, he said he's almost totally improved of the language function up to 95%. As you can see, although you cannot understand the Chinese, but you can see he's speaking fluently. So in this case, I learned that the Broca, the Broca area, the Broca actual function is like a motor, like a supplementary motor area. So you can safely remove the tumor precisely along this margin, and it won't cause any permanent deficits to the language if the lesion is in the frontal operculum. So how about this? This case, the lesion is arising from so-called Wernicke area. Actually, the patient developed aphasia before the surgery, and you can see this is GBN arising. Most of the people will say, oh, this is from the Wernicke area. And if you remove the tumor, the patient won't recover his language function. But I did pre-op DTI carefully, and I can realize the arcuate fiber is pushed away by this large tumor. If I can remove the tumor precisely along the margin, maybe I can preserve and keep the arcuate fiber intact. So this is the pre-op, this is post-op. As you can see, after the surgery, I preserve the arcuate fibers. So this is the right after the surgery. The photo shows I removed the tumor. And this is 18 months after the surgery. And you can realize, oh, the lesion is actually from the T2. It's not from the T1. It's not related to the Wernicke. So if you delineate the tumor margin precisely and remove it, actually you can keep the normal tissue intact and sew the arcuate fiber intact. So 18 months later, I did again the tractogram. As you can see, I removed this is the defect of the previous tumor bed. And actually the arcuate fiber is surrounding the supramarginal region. So the arcuate fiber is intact. So in this case, the so-called eloquent area tumor is actually a misunderstanding of the interpretation of images due to the distortion or the anomalies. So as you can see, the patient 18 months later. Yes, similarly, the patient said he had 80% better than before. He had already 80% recovery of the language function and much better than pre-operatively. So Although you didn't understand Chinese, but you can see that from the video, the patient actually speak very fluently. So the lesson, what I learned from all these cases in the OR, actually is compatible with the principles of Professor's microneurosurgery. And the most important concept is forget about the eloquent area, because every corner of the brain is eloquent. This is what professors told me. There is no eloquent area. Each piece of the brain has its function. So the most important is identification of the tumor margins and precisely remove the tumor. And actually you can keep the fibers intact and keep the patient neurology intact. So this is my conclusions. Identification of embryologic origins, the so-called compartments of glioma is essential. And also we have to know the tumor compartment and related fibers, decide the best approach based on the tracts and using the external navigation. And the most important is the dissection works in the lab. Will flatten your learning curve of glioma surgery. But unfortunately, a lot of people try to use in the post surgery that just put the trocar into the cortex and to the lesion, and actually they damage a lot of innocent fibers. And also they murder the chances of improving your microsurgical techniques. And a lot of people, they depend on the fancy images and neural mapping and monitoring, especially wet cranialotomy. But this should not be over-trusted if the interpretations are against the principles of microneurosurgery and acknowledges your anatomies and tumor behaviors. Thank you very much. This is the lessons what I learned from the OR.
Thanks a lot, Professor Stanford, for this excellent presentation and the lessons that we all learned today from your cases. My question to you, what about recurrence rate in your field?
Sorry, Sam, your voice looks like blurred, very low.
Recurrence rate of use cases.
Your voice is not clear, Sami. Your voice is not good.
Is it clear now?
Yes, clear now.
Better now.
Yes. I am talking about recurrence rate in your cases.
Yeah.
Now, Dr. Same, I want to make a small comment. Can I make a comment?
Okay, okay.
Dr. Hasu, that was a wonderful presentation with some beautiful messages. You said that the tumor is confined. You should find the edges. The tracts are displaced, and you can go around the tumor and you can resect the tumor. And your dependence on monitoring, on dependence of imaging may not be that much. This is what you said.
Yes.
I want you to read my article on this subject, where we have said absolutely the same things. You must read my article that these low-grade gliomas are confined tumors. They displace the adjoining structures, they displace the tracts, and they can be removed en masse. And there can be a plane of dissection between the tumor and the normal tracts. Adjoining tracts, including motor tracts, as you mentioned, are not invaded by the tumor. They are not arising from, the tumor does not arise from there, but they are displaced and distorted. So if you can find a good plane of dissection, you can remove the tumor. So I will invite you to read this article of ours, and you should, go further in your surgical strategy.
Yes. Thank you, Professor.
Have you read this article or no?
Yeah. Thank you, Professor.
Thank you. Thank you.
Thank you, Professor Heso. I am talking about recurrence rate in your series. Please check chat box. Okay, any comments from faculty? Okay, thank you, Professor Heso, for your excellent presentation. And
Thank
now
you
we
very
will
much.
shift to next speaker, Professor Debujari. Please start sharing your screen. Please unmute yourself.
Shall I share my screen now?
Yes, yes, sir.
Thanks, Dr. Same and John, for this opportunity. And I would restrict myself to a case I have recently come across and managed, and would probably ask you questions as we go along. Can you see my screen?
Yes.
Okay. So basically, I'm going to talk about a posterior fossa tumor which presented to us in emergency. This is a 27-year-old girl who's right-handed and who has had who has delivered a baby, her first baby, about 3 weeks prior to the presentation. She presented with multiple episodes of dizziness and loss of balance initially while getting up, and then later on frequent falls, and one episode of transient loss of consciousness for 3 to 4 minutes was the first time they contacted us. She was in a fairly bad shape at that time. She had also complained of occipital headache and neck pain along with these symptoms. And then she started developing weakness in both upper limbs, dysphagia for solids and liquids, and progressive change in voice for about 2 weeks. By the time she reached her, she had blurring of vision and diplopia. And 10 days prior to she came to us, that is the time when she had that fall with acute deterioration in sensorium. And the local neurosurgeon inserted a shunt, and then she was referred to us for further management. This was the scan which she brought with her. I think a non-contrast scan was done at that time. And you can see a large lesion which is involving the brainstem over here. And you can see some dilated vessels around it with hydrocephalus, obstructive hydrocephalus, and the periventricular lucency. So I think the first question would be, I mean, was the local neurosurgeon right in putting a shunt or not? Anybody would like to say? I think it is again a contentious issue these days. Whenever it is possible, we try to remove the tumor. That is our own practice. And we do not use pre-operative shunts. We would use a EVD or a ETV just before shunt. If we think we are, ETV will be used only if we think we cannot remove this tumor. EVD will be done regularly before you tackle such a large tumor. But the shunt was already done by the time she came. And when we examined her after her arrival here, she was conscious, coherent, and oriented. Extraocular movements were free and full, but there was horizontal gaze evoked nystagmus bilaterally, and there was downbeat nystagmus as well. The facial sensations were normal. Tongue was deviated to the left. Tongue movements were restricted bilaterally. Uvula was deviated to right. Right palatal arch was lower, and there were decreased movement of the palate, and the gag reflex was weak bilaterally. So I think the motor sensory system also showed that the shoulder shrug was also weak bilaterally. The power was about grade 4 in upper limbs. All deep tendon reflexes were brisk. Plantas were I think it is wrongly written. They were extensors, and sensory system was not reliable because she was remaining fairly drowsy, and she could not express herself so well at that stage. And finger ataxia was very, very prominent. So this was the scan which was repeated. You can see that the ventricles have nicely collapsed, and you can now see the tumor better. This looks hypointense on T1 weighted images with some areas of hyperintensity suggestive of recent hemorrhage. And you can see some cystic or necrotic areas with some areas of hemorrhage here, and prominent vessels at several places with one large vessel here and another one over here. And these are small hemorrhagic areas within the tumor all around. You can see that it is situated on the dorsal aspect of cervicomedullary junction. It is going down further. And this is how it looked on the MRI scan. There was some area of hemorrhage which was not taking up much contrast, but rest of the lesion was brightly enhancing, and the lesion was going down up to upper border of C2. And you can see that the hemorrhage was very clearly seen on these images. And the other thing that had happened, which is probably responsible for her weakness in the limbs, is that she had developed severe edema in her upper cervical spine with a small syrinx which had formed over here. So we're dealing with a cervicomedullary tumor with syrinx, a brightly enhancing tumor with certain areas of hemorrhage. And this was the CT scan with contrast. We actually tried to do a CT angio, and it showed us that there was prominent vessels, tortuous vessels. So I think the diagnosis by all these images was very clear that it was a giant cervicomedullary hemangioblastoma with recent hemorrhages. So we looked at risk of hemorrhage in hemangioblastomas because this is the first case I have encountered of solid hemangioblastoma, which has actually bled. And there is a good analysis available, a database of 277 patients published in 2005, which showed only 7 cases of spontaneous hemorrhage. And the predictability was very, very low. And an important indicator for the probability of hemorrhage was the tumor size. Tumors only over 4 centimeters actually bled in this small series of 7 cases out of these 277 patients. And they actually made a statement in their conclusions that hemangioblastomas smaller than 1.5 centimeters harbor virtually no risk of spontaneous hemorrhage. A contrary view was published a few years later by Dr. Shekhar's group from Washington, with their experience of bleed happening even in smaller tumors of 1.5 centimeters, where 2 of their patients out of 55 patients of hemangioblastoma they had operated, 3 of them presented with hemorrhage and 2 were small out of those 2. So they felt that other factors such as genetic predisposition, etc., were probably important rather than just the size of the tumor. The other factor which we were considering is that she had virtually a very good uneventful delivery, and all this started afterwards. So does the pregnancy has anything to do with these kind of hemangioblastomas? And there is some reference to this in the literature, that there is an accelerated growth of hemangioblastoma in pregnancy, and this happened due to the pro-angiogenic factors which happen in most of the pregnancies, and they can increase rapidly, and it has been reported before. And the pro-angiogenic state of pregnancy is blamed for this. Both PIGF and VAGR-GFR are increased in these ladies. Other investigations were done to check if there were other stigmata of multiple hemangioblastomas like von Lippel-Lindau, and fundus examination showed that there was no retinal hemangioblastomas. Ultrasound of the abdomen was normal. There was no polycythemia. We decided to proceed with DSA. And the idea was to find a feeder and probably, if possible, to embolize it. But we found something very strange. You can see that the vessels are looking pretty narrow. They're looking thinned out. And though you can see the increased vascularity of the tumor, it is not to the extent as you would probably consider to happen looking at the MRI. There is, of course, a large area of staining in the venous phase, but on the arterial phase, it doesn't look as scary. And most importantly, even the parent vessels, the bowing, etc. of basilar is seen, the displacement is seen, but you don't see them very large and tortuous vessels here. These are pictures on the other side. And again, you can see that though the tumor is staining, there is no sort of dilated or enlarged vessel seen. And the carotid circulation also looked reasonably okay. But what is important is even this looks a little bit like spastic vessels, thinned out vessels. So angiography was unlike hemangioblastoma, and there, for some reason, there was severe vasospasm. And then our angiography colleagues said that this can probably be related to her postpartum status. So we looked at the literature for this, and there seems to be a good review of what can happen in postpartum reversible cerebral vasoconstriction syndrome, which is now known to be a good syndrome. It can happen in about 10% of all the, almost 10% of patients in this CRVS syndrome, RCVS syndrome rather, belong to the postpartum period. And you find that patients can have acute onset of severe headache, segmental vasoconstriction, no evidence of hemorrhage, or fluid analysis seems to be normal, but there is a, you can get cerebral infarction, severe edema, you can actually go to ischemic strokes, and you can get a good cortical subcortical hemorrhage. And apart from this, it is not restricted only to the Western world. It is also seen in China, according to this, where they saw 12 cases. And this fulminant presentation can also be seen in some cases. So I think probably this vasoconstriction was related to this kind of a phenomena, and this probably played some role in her worsening. So what are our options? I think definitive treatment is, of course, surgery, and this is very well documented. I think though we know that all the hemangioblastomas should be operated upon, it becomes much easier to operate on a cystic hemangioblastoma, especially in cerebellum. But when you look specifically at brainstem hemangioblastomas, this is a series of 33 patients from China, and they have shown that only 4 cases were cervicomedullary out of this, and cystic tumors can have excellent outcome. But when it comes to solid tumor, combined strategy of preoperative embolization, which was virtually ruled out in our case, hypothermia or hypotension is actually recommended by these people. And this is a paper from SGPGI, one of the large institutions in our own country, where they described their experience of 19 cases. Again, 3 of them were cervicomedullary, and they have actually shown that 2 patients succumbed in this, but significant improvement was achievable in all the patients who survived the tumor excision. And leaving tumor capsule adherent to the brainstem is something they have described as essential kind of a maneuver to preserve these patients in for a good outcome. This Korean series shows about 13 consecutive solid brainstem tumors, and out of them, 4 cases were I think cervicomedullary, and they have said that planned near total resection or subtotal resection, even in a piecemeal fashion, can be attempted, as en bloc resection in this area may be difficult. So pre-surgical devascularization was ruled out because of this kind of severe vasospasm. So we actually talked to the oncologist that was it possible to devascularize the tumor by medical means, and bevacizumab has been known to reduce the vascularity, and it is used, as you are aware, in several malignancies. And we looked at its use in hemangioblastomas, in ocular hemangioblastomas. It has been used right from 2012, and there are cases reported where they have suggested that it could be used for CNS hemangioblastomas. But I could find actually only 1 or 2 cases where it has been used. This is for cervical cord hemangioblastoma, and the clinical trial, which was actually sponsored by the Dartmouth Medical Center, had to stop because there were not many patients accrued in this study, and they have actually talked about only 1 patient's result where they had some amount of hemorrhage. So you may not be able to use Avastin. It has not become very popular for cerebral hemangioblastomas because you may be allergic to bevacizumab. It delays wound healing. I think most important thing is that there can be serious tumor bleed reported, and our oncologist as well as oncologists from one of our premier institutes in Mumbai, they refused to administer any Avastin to this patient. So we ended up operating on this patient, and you can see the swollen cervicomedullary junction. I actually did this ICG to see where the blood supply was coming from, and this clearly looked as if this was completely blocked, and the blood supply was coming from a vessel over here and another vessel at the depth. So we started removing this lesion, what we thought could be safely removed, and we had to do this piecemeal as it was not bleeding too much, and we have been able to get 1 nodule out. As you could see earlier, it was a multinodular kind of a lesion, and this was the thrombosed vein which we encountered. This is something we see in glioblastoma rather than in hemangioblastoma. It was the other feeder which we coagulated and created a plane. So it was like supplied by, it was multi-compartmental kind of a lesion. But there was a reasonably clear delineation, and there was a reasonable gliotic plane, as you see, as the, though it is a piecemeal excision, when I'm bringing out this, I can see a clear margin. And eventually we got a good plane and we got into the 4th ventricle, as you can see towards the end of this. So we started off with this big nodule. Once it was debulked, we could remove this nodule completely. Then we went for the second nodule on the other side, and then we went to the top to get this whole thing out. And we managed to, eventually get a complete excision. Postoperatively, she could actually be extubated on the 2nd postoperative day. We were completely prepared to do a tracheostomy on this patient, planned tracheostomy. And though the one cord was immobile, the other cord was compensating very well. And therefore, this patient actually did not need to be tracheostomized. She went another FOL after 4 days, and it had shown that the cord was getting some mobility. And she was then actually recommended to start on swallowing therapy from day 5. This was the postoperative CT scan after 6 hours of surgery. The biggest problem we had in this patient was we could not get her head up beyond 15 degrees or so. As soon as it was raised to 30 degrees, she had severe postural hypotension, and it required fludrocortisone before her mobilization could be started, which took more than 2 weeks. Balance and gait also gradually improved. There she developed a central venous catheter infection 1 week preoperatively, and I think 10 days postoperatively she was on this intravenous injections, and that resulted in some further delay, but at the end of 20 days she got out of ICU. This was a classical hemangioblastoma in the sense that there were and there was no nuclear atypical, and immunohistochemistry suggested a definite capillary hemangioblastoma. What was most important is that there was a large ectatic vessel with newly formed thrombus, and we confirmed that it was probably arterial, it was not venous. And large areas of intratumoral hemorrhage were seen patchy in several areas. And then at the end of 3 weeks, we did her first MRI when we were deciding about letting her go home. And the MRI shows that there was considerable reduction in the brainstem edema, and not only brainstem edema, even edema in the upper cervical spine. And you can see on contrast, there is just a patchy enhancement over here, which our radiologists feel is not a left nodule, but probably just scarring. And at the end of 2 months, she has now come walking independently. You can see that the edema has further reduced. The fourth ventricle is seen normally. And this is just an area of gliosis. And she has been able to, her dysdiadochokinesis and her finger-nose-finger movements have improved considerably. And you can see that there is no enhancing nodule anymore seen on her MRI. And she can now smile. You can see that her tongue was deviated. That has also come back to normal. So I think the message I would like to give is that brainstem hemangiomas are challenging tumors. Pregnancy can lead to accelerated growth of this lesion. Incidence of hemorrhage is small but should be considered while considering prognosis and weighing surgical risk. Complete surgical removal remains the treatment of choice. Anti-angiogenic drugs may be used. Embolization and radiosurgery may be used if you are unable to do that. And in our patient, I think the vasospasm in the postpartum period and associated thrombosis of vessels probably helped decrease the blood circulation and ease excision in our case. I was really very much worried about operating on this patient because you may end up, if not, lose the patient, you may end up with a quadriplegic patient who cannot eat or drink and is tracheostomized. And it is very, very difficult to see a patient 27-year-old at this stage. So the relatives were very, very not only cooperative, but understood the problem. And in spite of talking about a 5% risk of death and severe disability, they decided to go ahead with surgery with us. And fortunately, we have had a good result. I would appreciate comments and any suggestions.
Thanks a lot, dear Professor, for this excellent presentation and the experience that you have shared with us today. Is there any question from panelists? I think you have give us the all analysis for this excellent case, and that's why no question to ask. Thank you, Say.
Dr. Samay, let me ask but let me talk on this subject of hemangioblastoma near the brainstem. See, hemangioblastomas near the medulla are very common. You see, that location of hemangioblastoma is, I will consider this location as one of the most dangerous neurosurgical problems because they are stuck to the brainstem, to the medulla, and sometimes the plane of dissection is absolutely not, you can damage the medulla and you can create bilateral lower cranial nerve deficits. So hemangioblastomas, large hemangioblastomas in this location are dangerous. They are common, they are life-threatening, and they have to be done very beautifully. I will compliment Dr. Dev Pujari for a wonderful result. You see, he has shown one case which was dangerous, which was stuck to the medulla. Dissection could have been absolutely dangerous. To take that risk, I will say it is a very fantastic outcome. Now the thing is, the person is completely cured. These are benign tumors and you have cured. So take the risk, cure the person.
Thank you, Atul.
Thank you, Sir. Now we will shift to next speaker, Professor Atul Goel. Please start sharing your screen.
Okay, my dear Dr. Samay, you have asked me to talk on the lessons that I have learned in the operation theater, lessons that we learn in our, you see, operation theater is our playground. Operation theater is our life. We live here. We learn how to deal with patients, how to improve our surgical skills, how to treat our patients better, and how to progress in neurosurgery and in life. Dr. Sameh, there is some noise coming. Can you, John?
Okay, I'm sorry, let me get it.
It's okay now.
Okay.
Okay.
So my fortune was that I worked in very busy departments. I worked in public hospital, which was completely free for the patients. That gave me an opportunity to work on difficult tumors, complex tumors, vascular tumors, and to learn the art of neurosurgery in a very heavy neurosurgical department. So over the years, what I have learned is that every neurosurgeon should have a plaque in front of his clinic that states there are some patients whom we cannot help, there are none whom we cannot harm. So that is the principle of our subject, that we should try to help our patients, but we can harm our patients. So we have to be good, and we have to be absolutely good, because any mistake can create morbidity, any mistake can create death. On the other hand, a successful operation can give new life. So it is a matter of life and death for the patient. So there is no way we can not learn from what we have done and what complications we have encountered. That are the main teaching lessons for us. We must, as neurosurgeons, realize our infinite potential for harm. We can be absolutely create disasters for the patient. Even small complication, it may look like very ordinary for us, but it is huge for the patient. If you are restrained in your approach, if you are careful and restrained, that word is very beautiful word that I found in your approach, you are less likely to disturb me. So essentially, we should have a childlike curiosity, a sense of wonder, admiration and ignorance for the beauty of brain, for the beauty of the subject that we deal in. And we have to realize that in nature, in nature's infinite book of secrecy, a little, I can read this sentence from Shakespeare I got for you. So in my career of neurosurgery, which spans more than approximately 40 years now, I have been dealing with absolute vascular tumors. So this was intracavernous hemangioma, which are amongst the most vascular tumors, amongst the most difficult tumors, straddle with the internal carotid artery, straddle within the cranial nerves, and difficult problems. So these are the most vascular tumors, most benign tumors. And this is the first case probably in the history which is showing preoperative and postoperative resection in the year 1991. So about 31 years ago, these tumors were very difficult, probably impossible to operate within the cavernous sinus. And this was the case that I did in 1991. And I did several cases, and recently I published a series with 46 cases of cavernous hemangiomas, and with the learning, with the methods of controlling bleeding, with the techniques of controlling bleeding, techniques of understanding the nature of the tumor, techniques of understanding the philosophy of these tumors, how they are located within the confines of the cavernous sinus, within the dural walls of the cavernous sinus, how the nerves are displaced. So we went on learning and perfecting the art, and introduced this extradural approach, which some of you might have read. Pituitary tumors in the similar way can be vascular tumor, how to control bleeding, how to stop bleeding without coagulation, learn the art of demolishing the tumors, learn the art of breaking the tumor. Every tumor has a different way to demolish. Every tumor has a different confined nature, like gliomas we just heard, they are confined. Similarly, pituitary tumors are confined within the dural space. Learn the art of breaking the tumor, and you have a beautiful strategy and beautiful outcome for these benign tumors. You see, they can achieve very huge size, but they are confined. And that lesson has to be learned, and that we learned in our operation theater with several hundred of these pituitary tumors. We learned that diaphragm cell has a special relationship with pituitary tumor. And if you know the dural nature of how the dura is spread around the tumor and the intradural tumor of pituitary tumor, you can do a great job. What I want to show you is one beautiful tumor that I operated in 1995. So this tumor was operated elsewhere, and the tumor diagnosis was chondrosarcoma before the operation. So they went retrosigmoid and took a biopsy of the tumor. And after they took biopsy, there was a 4 liters of blood loss following a biopsy. And then the patient came to me, and this was the angiogram that we did. And you can see the huge vascularity. And in 1995, I operated on this patient. You see the intense vascularity of the tumor. We did a total petrosectomy at that time in 1995, and then I operated and I reached the tumor. And by the time I reached the tumor, I lost another 4 liters of blood. And I said to the patient that this is an impossible tumor and it cannot be operated. He came back to us after about 6-7 months with the main issue was absolute giddiness. He just could not stand. And then I did embolize. I tried to balloon occlude the carotid artery and all, but that was not possible because he developed hemiparesis. So this was the post-operative after petrosectomy. And then I controlled the carotid artery and did a beautiful resection and complete. And in so many years since 1995, I have seen this young man growing into adult and young man having a family. So this was my success. And I will say that this took me ahead and launched me into vascular, surgery dealing with vascular tumors. This was one of my great success. I always think about it and always remember with pride and pleasure how it took me off into neurosurgery. We should know the miracle of blood. Blood is a divine tissue. We have to know how to coagulate, how to understand, how to do hemostasis. Every surgeon has a different way of achieving hemostasis. One surgeon, how he differs from the other surgeon is how he responds to blood loss, how he controls bleeding, how he avoids coagulation, how he progresses amidst bleeding situation, and how he resects and completes the operation. So these are some philosophical things which I want to show you. I caused the bleed, God stopped the bleed. I dressed him, God healed him. So in my life of neurosurgery, I have dealt with various kinds of meningiomas, huge meningiomas. This was at that time, about 30 years ago, one of the largest meningiomas ever removed in the history of neurosurgery. This was 1,800 grams. And this was removed. There was some tumor left behind. I have removed complex and very intense. And this patient is still alive after so many years of complete resection. You can see in 1994 what kind of petrosectomy I had done and how I had achieved quite a radical resection. I want to show you one complication that I had. This was a petroclavial cavernous sinus tumor. And in my youth, in my young neurosurgery, radicality was my aim and absolute complete resection was my aim. And I removed this tumor completely, as you can see. But the problem is this patient developed hemiplegia after surgery in 1996. And he keeps coming to me intermittently with, now the hemiplegia, of course, is much better, but he still has quite a bit of disability. So this patient taught me quite a number of lessons as to how the tumor should be resected, where I should be safe, where I should not go further. So several lessons from this tumor. And I believe this was quite a teacher for me in my entire life of neurosurgery. So in meningiomas, I made some philosophical statements for you. Tumors are a spatial problem demanding spatial solution. We should be radical always. We should be aggressive always. but safety should be our aim. The surgeon's role is to respect the space-seeking faculty of the tumor and hence attempting in reducing the bulk or to increase the space available for the tumor to be. So our tumor is a space occupation. We should create the space and we should be safe. That is the lesson I learned from this case. And whether the meningiomas are curable, how much you should resect, whether Simpson grade 1, Simpson grade 0 leads to complete curability from the meningiomas. This, I will like you to read this beautiful article. I will say safety first, aggressiveness always should be there, but safety is the parameter that will determine the outcome and determine the success. Is total removal, like same thing in acoustic tumor. Acoustic tumor, facial nerve disability is an absolute disability. So now over the period of time, I have realized and I have understood, and you can see from the title of this paper, is total tumor resection and facial nerve preservation possible in massive tumors? My take on this should be that it is not possible. Always you should try to preserve the facial nerve, and leaving a sleeve of tumor along the facial nerve is always safe for the patient and always safe for the beautiful operation. Similarly, in malignant tumors, you see malignant tumors, we like to remove radically, we want to be radical, and we want to achieve a beautiful post-operative MRI and all those things. So this paper of mine where we said that beyond the lure of technically sweet, we should be radical, but we should be safe. You know, and in this article, if you read, I mentioned about Hiroshima, the person who made the atomic bomb, and he put on, the bomb was placed on Hiroshima, and he said, I did a technical wonder, but whether the technical wonder was good enough and whether it should have been done or not done. So we should realize whether our radicality is good for the patient or not. As you know, this craniovertebral junction stabilization is my wonderful and very favorite subject. I introduced this technique in 1988, and since then we have got several, more than 3,000 patients where we have done atlantoaxial fixation. Anatomy is the key. Understanding of vertebral artery is absolutely mandatory, but we should know that the vertebral arteries sometimes go very deep into the facets, and you can create a disaster of vertebral artery. You see, this vertebral artery anatomy has to be understood and absolutely understood. What I want to show you is a complication that I had. This was a complex case of craniovertebral anomaly with OPLL and very dangerous facets. You see the vertebral artery inside the facet of C2. And during insertion of screw into the facet, I damaged the vertebral artery. And you see, this is a beautiful realignment. The OPLL has disappeared, but there is a big infarct and this patient developed bilateral blindness. And I have to tell you, whenever I think about this patient, I get shudders and I get disturbed by this patient. Despite the fact that he improved in the power of his limbs, he developed blindness, and this blindness, he himself is disturbed and he keeps disturbing me all the time. And since then, I have developed my techniques of saving vertebral artery, techniques of mobilization of vertebral artery. That case has taught me so many wonderful lessons in my life of craniovertebral junction. And this is one paper I am showing. There are several other techniques which I described subsequently of saving and avoiding the vertebral artery. Other thing is the most beautiful and most wonderful operation that I like today is surgery on AVM. And we have discussed about in various forums that AVM should be either treated by surgery or should not be treated at all. These kind of, when there is a bleed, we can have an indication, yes, this has bled and it may bleed again. So radical surgery, and not radical, this word is not good for AVM. AVM, the only word is complete resection. There is no radical word or incomplete resection. Complete resection is possible, is dangerous, but that is the treatment for large. There is no midline treatment or half treatment or some radiosurgery or half embolization. That is not the treatment. If you have to treat, you have to resect. This is difficult, but this is possible. But you have to know your own talent. You have to know your own skills, whether level, whether you will be able to remove, whether you are not able to remove. Patient giving consent, okay, remove is no way. That is not the way you have to do these kind of surgeries. See, this is another AVM which has bled, difficult, and I resected this AVM, and this patient is cured. So the thing is, the possibility of cure is there. But you have to know whether you can do it, whether you cannot do it before operation. If you go in the operation theater, create a bleeding disaster, that is absolutely not acceptable to you and to the patient. I give you an example. This young girl comes with such a massive AVM, and the only problem is headache. So you have to know before operation whether you will be able to remove this AVM completely and successfully. You have to know completely. Of course, there can be surgical disasters, but you have to be reasonably sure and reasonably certain that you can remove it completely and safely. If any kind of hemiplegia and unconsciousness will not be acceptable, even now she's saying, okay, doctor, operate, I give you consent for surgery. That consent will be very useless if during operation you find yourself in an operative disaster. So this patient, of course, was given a beautiful smile and beautiful AVM resection. This is another patient which came with only complaint of giddiness. Now only complaint of giddiness, whether you will like to operate this AVM. This is not absolutely difficult, but quite a difficult AVM. You operate and you create hemiplegia. That is not acceptable. So I said, no operation for you. So this patient went back because he came only with giddiness, and he continued to have giddiness. And after 6 months, he comes back to me and said, doctor, you have to operate no matter what you do. He gave me consent and I removed it. But I have to tell you that if he says, doctor, operate, that consent is not a valid reason to operate. You should be able to operate. You should have that. Even if he's saying, doctor, operate, and you for giddiness, you create a neurological complication, that may not be an acceptable situation. So patient giving consent is not a certificate to operate. You should be able to understand that, yes, I will be able to operate this, and I will be able to resect this, and I will be able to give a new life to this patient. Another patient, only symptom with headache, whether you will like to operate or not, that is on you. Now this patient has also come with the only problem of convulsions, and I operated this patient beautifully, but this patient had parietal lobe sign, difficult to calculate, difficult to speak, difficult to name, but he had convulsions, had stopped, he was okay, but there was a complication. So in AVM surgery, you have to be absolutely sure that you will not create complications, because these are benign problems. These problems, your patient will live. These are not glioblastomas where the patient will die. So this another patient comes with only giddiness, and I operated. This patient comes with only giddiness, and I resected it. So these are surgical successes. AVM surgeries are absolute beautiful micro neurosurgery, which you have to learn and which you have to be absolute. This is another patient with only complaint of giddiness, and I removed this AVM beautifully. This is after a few years of surgery. The question is, this patient also, I told that this patient should not be operated. You can imagine this is the AVM, and whether you would like to touch this. This can be absolutely dangerous. I told the husband, no, your wife can die after operation. So he said, okay, just go ahead. You see, but I operated successfully, but you have to be absolutely perfect in taking decisions. This is motor strip AVM, and this is post-operative. What I want to show you is this case. This case, patient came with only problem of convulsion. And this patient, I got a phone call from the health minister of India saying that you are the best and you are the absolute and this and that. And, in that game of ego and pride, I operated this AVM and I removed this AVM beautifully. But, I have to tell you, this patient developed hemiplegia after operation. I still shudder with the thought that whether that phone call from the Home Minister was the issue that made me operate this case, or whether it was operable or whether it was not operable. Of course, I operated, and I think it should have been operated, but that phone call still gives me, a sense of a little bit difficulty that whether that phone call made me took this decision. So patient giving consent, there should be no extraneous circumstances to take a decision about AVM surgery. Nobody should influence you. Yes, you operate. You should operate only when you think you can operate. This decision of operation is absolutely important, and this lesson I learned from this case. So to be conscious that you are ignorant is a great step of towards knowledge. Science thinks, technique does. A good surgeon is one who knows when to operate and when not to operate. This is particularly true in AVM surgery. Technology can make you bold, but it cannot make you wise. Ethics and our subject of neurosurgery are very interdependent and very closely related. As this is my lesson to young surgeons, as is our anatomy, so is our surgery. Sitting in front of computer cannot make one learn any kind of anatomy. If knowledge is infinite, so is ignorance. So there have been dramatic advances in neurosurgery. The role of neurosurgeon has remained unchanged. We should love our subject. We should try to learn more and more, and we should be doing our subject with our heads down. We should have complete confidence, but not err towards overconfidence. We should be able to give new life to our patients. We should try minimize harm to these patients. And this subject is great. Neurosurgery is absolutely fantastic. We have to learn to become good neurosurgeons. Thank you very much.
Thanks a lot, Debo, for this excellent presentation and lessons that you have learned us today. And I think the important message in this lecture is do no harm and study your patient well. If you can't do it, please refer it. And my question to you, do you believe in preoperative embolization for such bleeding lesions?
See, Dr. Sameh, my indications for embolization, I do not do any embolization for AVMs. I do not do any embolization for any kind of meningioma or any other tumor. Only tumor where I will like to do embolization is glomus jugulare tumor, where embolization might help. My contraindication for embolization is for nasopharyngeal angiofibromas, which can be very heavily vascular. You see, I have got 2 patients in my series of nasopharyngeal angiofibromas where following embolization, they became blind. So no embolization for any tumor except glomus tumors. That is my philosophy, Dr. Sameh.
Thanks a lot, Debo. Is there any question from panelists? Thank you.
Thank you, Dr. Sameh. And I enjoyed, you see, this was a different subject. You gave a subject where what lessons to learn from your operation theater. And I was thinking about it for more than 15 days as to what to talk on this subject. So I made this presentation. I hope you enjoyed and enjoyed my experience with this presentation.
Yes, it was perfect, my boy. Thank you.
King is back.
Thank you.
Thank you, John.
Okay, and now we will shift to next speaker, Professor Ibrahim Sbih. Please start sharing your screen.
Hello, everybody. Can you see my screen?
Yes, it's okay.
Right. My name is Ibrahim Sbih. I'm from Amman, Jordan, and this is the Farah Medical Campus where I work in Amman. It's a new neurosurgical center. Some pictures from Jordan, Wadi Rum. On your way to visit Petra, you have to pass through Wadi Rum, and there you would feel like you are on the planet Mars. This is Petra, one of the 7 wonders of the world. This is the Dead Sea, the lowest point on Earth at 420 meters and getting lower and lower, where you can float on top of the water because of high salt content. And Jordan is a very religion tolerant country. Jordan site of baptism is one of the holiest centers in Jordan. And here the Pope visiting us. And Jerash, the Roman amphitheater cities, second only to Rome, and the lovely countryside of Jordan. And the Black Iris, which is the symbol of Jordan. So I think the title is speaking about itself. I thought that one should present a case where one learn a lesson, and I did learn many lessons from just one case of a parasagittal meningioma. As you know, parasagittal meningioma are classified according whether you are involving the anterior segment of the severe sagittal sinus, middle segment, or posterior segment. Sandow and Brucci came up each with his own classification according to whether the superior sagittal sinus is involved. Both Mark and Jax visited us here in Jordan, and here we are in a meeting with His Majesty King Abdullah. So these are the classifications of how many wards are you involving in the superior sagittal sinus. One ward getting into the cavity of the sinus and then proceeding to obliterate it completely and go to the other side. So the worst type is the type 6 or grade 6, where you start one side and then you cover to the other side. My series of these parasagittal meningiomas in 30 years' time, 138, mostly females. In this series of 138, I had 32 cases of sinus invasion, whether partial or complete occlusion. I had bone invasion in my series, 25 cases of the 136 cases. And brain invasion, I found it in 15 cases of mine. And we published our 250 consecutive meningioma histopathological series recently in the American Pathology Journal. Of these parasagittal meningiomas, 10 cases were bilateral parasagittal. Bilateral meaning bilateral. So you cannot really decide whether they started from the right or the left. I achieved Simpson grade excision 1 to 2 in majority of cases. I'm very, very aggressive in these cases, and I followed them up for a long period of time. The average was 80 months. I have not lost any single case of these. Morbidity was 11%, either CSF leak or one infection, epilepsy, pyramidal weakness, dysphasia, and cognitive function in 1. Residual was found in 8 cases. We just keep them under observation. And on prolonged observation, we found progression in 6 cases. I operated in 2 and gave gamma knife in 4. And just have to remind you of Jordan being the first country in the Middle East with the acquisition of gamma knife back in '96. And this is me, about 26, 27 years younger and thinner. Illustrative cases of these bilateral parasagittal meningiomas. This man of 56 with the total occlusion of the superior sagittal sinus was totally removed, and he was followed up for about 12 years without recurrence. And this also lady with this very aggressive bilateral meningiomas and also been followed up. The case that I want to mention where I learned so many lessons is this invasive bilateral parasagittal meningioma obliterating the superior sagittal sinus, Sindhu Brucci grade 6. He's a 46-year-old man, male from Iraq. And for 3 years, he complained of headaches, generalized tonic-clonic seizures, which were not at all controlled, blurring of vision. He became urinary incontinent and had weakness in his lower limbs. That's when he came to us. And this was his picture. You can see this is a grade 6 bilateral parasagittal meningioma, obliterating the superior sagittal sinus, affecting his lower limb motor and urinary center. And you can see the amount of shift of the anterior cerebrals and their branches. And this particular picture can show you this very clearly. So with these images, you can say this occlusion, complete occlusion of the sagittal sinus, that is a grade 6 Sindao-Brocchi classification. We do all the investigations regarding visual acuity, visual fields, endoscopy, optical CT, and I insist on doing Karnofsky performance scale for every brain surgery I do, pre and post-operative. His EEG was very disturbing. There was evidence of bilateral frontotemporal slow wave activity. And as I said, his epilepsy was not well controlled. He was on so many anticonvulsant drugs, epinephrine and lidocaine, and we found that he had shoulder dislocation because of the severity of the fits that he had. So I operated upon him, and I show you the steps of surgery. In supine position, we used the navigation, ultrasonic aspirator, and Doppler probe to see where the occluded sinus begins and where it ends. So here, this is the right side, this is the midline. First, we drilled the invaded bone, which was invaded, so bone invasion was part of this case. So we are here midline, sagittal sinus. This is the right side, here this is the left side. I started on the right side using the ultrasonic aspirator. And whenever I have partial occlusion, what I do is this trick, which I learned very, very long time ago, is that I open the sinus, put a stitch, open the sinus, take the tumor out from the sinus, and then continue doing the stitches until I remove it completely. That is, if the sinus was partially obliterated. I'm very aggressive with these, and I think this is the best chance to give them. So here, in this case, we are still on the right side. You can see you have to preserve this vein, which is at the anterior end of the occluded sinus. So the occluded sinus starts from here till here. So this vein tells you that this is very important collateral vein that you have to preserve. Parasagittal meningioma surgery is all about draining veins and superior sagittal sinus. Here we finished doing our stuff on the right side. We went on to the left side. Again, using the ultrasonic aspirator, still tumor within the occluded superior sagittal sinus. We preserve this vein. Now I put a stitch using the probe, the arterial probe, to see which part of the sinus is open, which part is closed. And I put my stitch here, and then I cut the sinus completely going down to the forks. So that's what I'm doing now, is to remove that tumor from within the sinus. Now, concentration on the left side, removal of the tumor. And here you will come across the branches of the left anterior cerebral artery, pericallosal and callosal marginal. Have to differentiate between the arteries that's going to the tumor and the arteries that go into the brain. And sometimes you have those in pass. This is the branches of the pericallosal and callosal marginal now on the right side. Continue removing the tumor. And this is the lower end. Here we finish the anterior end, the middle part of the occluded sinus. This is the posterior end, this is the forks. And again, this is very important vein going to the open part of the sinus, which you have to preserve. So at the end of the day, we have removed the involved sinus from here till here completely with the forks. This is the left side, this is the right side. Cover it with Surgicel and come out. So what's the lesson here? We started our surgery at 2 p.m. because we had something to do that morning, and we finished the surgery at 10 p.m. It took about 8 hours. This patient suffered a violent attack of generalized tonic-clonic seizure. Still, the Mayfield clamp was still on. The anesthetist was a little bit quick to bring the patient to consciousness, and we noticed that there was some bleeding from his mouth, denoting that he really had a good violent seizure. So I had a discussion with the anesthetist. What should we do? The anesthetist said that let's just put him back on the ventilator because this is going to be subclinical and clinical status epilepticus. Let's rest the patient and give him loading of anticonvulsant, etc. I said, no, we have to know exactly what's going on. And I insisted on having a CT scan. We did, and I was right. There was an extradural hematoma. So I took him back, removed the extradural hematoma, started at 1 a.m., finished at 2:30 a.m. We kept him on multiple sedatives and until we extubated him, and this is the immediate post-operative, no tumor and no extradural. We successfully extubated him and kept him on adipocane infusion, and he woke up successfully. That's him, immediate post-op. The following day, actually. And he was discharged from hospital with full discharge summary that we insist on doing. We never write a one-page discharge summary. It has to be 15 to 20 pages, putting all the facts and all the results in figures about this patient. So this is his discharge summary. And his histology, his pathology showed that this was aggressive meningioma grade 2. That's how it was reported by our histopathologist, American boarded. And this is the last page of his discharge summary. So brain invasion was documented. And the immune staining for all the immune stainings that we do was put on P53, P63, estrogen, progesterone, Ki-67, etc. And we followed this patient for about 7 years. He was well, and he had no recurrence. So what did I learn from this just one single case? Lesson 1. Pin fixation is used widely in neurosurgical practice for whatever pathology you are doing. Congenital anomaly, epilepsy surgery, tumor, vascular surgery, whatever. Pin fixation is part and parcel of modern neurosurgery. But what we don't recognize that pin slippage can occur. And people actually documented the slippage of the pins from here till here, from here till there. So it is a fact, it is a reality. And the slippage is not specific for any manufacturer or brand of the devices. Although we know that the most popular pin fixator that we all use is the Mayfield. So the point fixation, fixation is either 3-point fixation or 4-point fixation or 6-point fixation. For whatever procedure you are doing, whatever position you are doing, you are going to use this fixation. So Mayfield is the most popular, so we'll concentrate on that. So many joints in it, so slippage can occur in any of these joints. Even in children it is more, because the thickness of the skull is little and the pins are shallow. So this is frightening. The FDA report 2016 reported 1,000 slippage in the period between 2009 to 2016. And this would cause problems, can cause skull fracture, breast fracture, hematomas, extradural, subdural, facial laceration, facial injuries, infection, also venous embolism. And if you are doing a procedure, then you will get inaccurate stereotactic navigation. It will halt your surgical procedure. It will prolong the surgical procedure itself. So these are the report from the FDA, and also many reports that appeared a long time ago, 1994, the breast skull fracture in children secondary to skull clamp devices. There were 5 patients, and those were operated for brain tumors, more in males. Another paper from Japan, 20 pin slippage in 3 out of 21 patients. Also, it was documented, the slippage, and these were the 3 patients being treated for epilepsy. And as you know, awake surgery or epilepsy surgery is more associated with the pin slippage. From Boston, 2017, complications of head immobilization in children. They reported 941 patients. 7 had complications and fracture. They have developed extradural hematoma. 6 of these required surgery. And all of these patients were children with posterior fossa tumors. Many other papers appeared documenting this. So it is an eye-opener that one should be careful about things that we take for granted, that this pin fixator is solid, it is okay, and so on. But you have to check every single case. So again, further studies in literature about the slippage of these pin fixators. Skull fracture, epidural hematoma, you can see there. Especially in this case, it was a patient who was on hemodialysis, so it was postulated that maybe because of the renal failure that his bony condition was affected. Again, in children and in adults. So we should not exclude adults because of thick skull. Like in my patient, a very thick skull. Iraqis, by the way, have very thick skulls, so it can happen. Fracture, extradural hematoma. And the causes of a slippage, there's something in the device itself. Mechanical failure, breaks, cracks, lack of maintenance, which is the most important factor in the third world country, lack of maintenance. Application of the device depends on you, how you apply the device, and whether the patient has some problem, like being a child with thin skull. Long-term anticonvulsants are known to cause bony disease, predisposed to fragile skull. Also, long-standing phenytoin and phenobarbital are to be accused of this. Tips of application that was also mentioned in the FDA report, that when you apply it, you have to avoid bony areas, soft bony areas, weak bony areas like the frontal sinus, the squamous temporal area, adjacent to the orbit. Whether you have a previous cranial flap, you're not aware of the site of the craniotomy, avoid the venous sinuses, avoid the courses of the nerves and the arteries. And always place the single, you have, of course, the Mayfield, you have one single pin on one side and two rocker pins on the other side. So place the single skull pin as close to the central line of the head of the patient, and the two rockers on equal distance from the single pin. You should also study the angle between the three pins. So taking the Nasian onion line, you have to come as close as possible to it. The closer you are to it, the better. So here, this is a better pin than this one. Here, the distance is big. Here, the distance is very almost zero. So this is more stable than this. So I've learned, the first lesson I learned, that pin slippage can occur in adults with very thick skulls. Can happen with all the precautions that you do. And since then, what I do is also to put a support between the Mayfield and the head of the patient. I want to fill the gap just in case there is a slippage, that the head of the patient would not fall down. The second lesson I learned, that the discussion I had with the anesthetist was very important to me. He insisted on just keeping the patient on a ventilator. By the way, this is the habit of the anesthetist. They want to go home. It's better for them to put the patient on a ventilator. And the excuse that they put is, let us give the patient some rest. This is a long surgery. Let him have some rest. This is not on. We should not give rest for the patient. We should get him awake on the table and see whether there are any problems. My motto in the theater is that no patients leave the table before being totally unconscious on the table. If he is not, there is a problem and we should know it. If I agreed with the anesthetist and put him on a ventilator, that patient would have died. So I'm happy, and I learned a lot, that one should insist on the ABCs of neurosurgery. Lesson 3, I believe that first surgery, I believed and I learned that the best chance for any patient is to have the first surgery, to go for a cure of the patient, no matter how formidable the tumor is. So attempt at complete removal for those parasagittal tumors, including sinus invasion. I've been doing this for the last 30 years. I'm very, very aggressive with parasagittal meningiomas. This way you decrease the recurrence. And I'm not afraid, I don't hesitate in operating and opening the sinus, take the tumor from inside and take a continuous suture as I do this. And always the name of the game in the parasagittal meningiomas is to preserve the collateral veins that keep the patient alive. With this, I finish. And again, I finish with the black iris simple Jordan. I'm happy to take your questions.
Thanks a lot, Professor Subih, for this excellent presentation. And I want to add some points to these lessons that we have learned today. One of them, don't lead others, lead your mind. Please check your patient and your instruments. Don't let time pass without taking any action. Double check is a must, so you don't let anything to your assistant. Please check behind him every step. Is there any question from panelist? Okay, thank you, Professor Bohim. Thank you.
Pleasure. Thank you.
And now we will shift to next speaker, Professor Hisham Basyouni. Please start sharing your screen. Thank you.
Yeah, good day, everybody. And thank you very much for your kind invitation, Dr. Sam and Dr. John, to join you again. I hope you can see my screen.
It's okay, and sound is loud and clear.
Okay, very good. So my topic about special surgical cases on neurofibromatosis type 2. First, some introduction. The NF2 was first described by John Henry Wizard, a Scottish surgeon, in 1822. In comparison, NF1 was described 60 years later by von Recklinghausen, and it's also called von Recklinghausen disease. The hallmark of NF2 is bilateral vestibular schwannomas. In von Recklinghausen disease, it is the cutaneous and the spinal neurofibromas. The incidence per number of births in NF2 is around 1 in 33,000 births. So it's much less frequently observed than NF1, which is around 1 in 3,000 births. Both are autosomal dominant diseases with a 50% rate of de novo occurrence. The gene locus in NF2 is on gene 22, and the gene product which is encoded is schwannomin or Merlin. In comparison, NF1, the gene locus is on gene 17, and the gene product is neurofibromin. The associated tumors most commonly are multiple meningiomas and spinal ependymomas in NF2, while it's, as I said, neurofibromas, cutaneous, spinal, and supratentorial astrocytomas in NF1. So the patient is a 12-year-old female patient who first, or the initial diagnosis was in May 2018, and she presented in another clinic with deafness, with facial palsy, hoarseness, and she had clinical palsy of cranial nerves 7 through 12. And this was the clinical symptoms occurred since 2017. And you can see here a tumor left side, which is quite big, which is going through the skull base into the infratemporal fossa. And you can also see that on the contralateral side, there's an intercanalicular tumor, probably a vestibular schwannoma. So also in the axial scans, you can see the intracanalicular tumor on the right side, which was asymptomatic. She had good hearing on the right side. While on the left side, you see this vestibular schwannoma probably, and she was already deaf at the time of presentation. And also this tumor partly destructed the petrous bone. And as you can see on the next images, it also directed and went through the skull base, through the jugular foramen, which was dilated into the infratemporal fossa. So at that time, the indication for surgical decompression was taken in the other institution, and the surgery was performed in July 2018. The histology was, as expected, a neurinoma, schwannoma, mostly Anthony type A type. And as you can see in the early postoperative MRIs, the good decompression of the brainstem was achieved, but there still was a large tumor left in the petrous bone, and also the infratemporal fossa tumor was untouched. So on follow-up in the other institution, the tumor progressed, showed clear progression in December 2018, and so there was again indication for surgery, but this surgery this time had to be abandoned due to cerebellar swelling, and the patient was unchanged clinically on the further course, but they introduced an Avastin trial because the tumor was considered not good operable, or at least not with a good risk-benefit ratio for the patient. So this was the MRI after the second trial in the other institution, and you can see that the tumor has enlarged indeed in a very short time. And now you can see also more invasion of the petrous bone, as you can see here, and which was actually completed and invaded by tumor at this time. And also you see recurring compression of the brainstem. So the patient was first presented to me in April 2020. Clinically, she had the facial palsy, incomplete, House-Brackmann grade 3. Of course, deafness still remaining, worse is dysphagia, and she had clinically a palsy, of cranial nerve 7 through 12. And at that time, of course, due to the brainstem compression, I recommended surgery. They were not ready for that at that time because they wanted to await the Avastin trial. So the patient came back after a bit more than 1 year. She also wanted to continue. She went to school and she wanted to continue her school term. So this was the MRI when she presented the second time. You see an obvious progression of the tumor, now greatly compressing the brainstem, the cerebellum, and you can see also the tumor goes into the external auditory canal, and at that time she had a discharge from the left ear, and she had ataxia. So also there was clinical progression. Not only neuroimaging progression. She had also an increase in the infratemporal fossa portion of the tumor. So at that time they were ready for surgery, and so of course this is a large complex lesion, and you have to plan the surgery. These are the coronal images, by the way, showing the compression, the external ear extension, and also the infratemporal fossa extension. So in this complex lesion, of course, you have to make a plan. You can see on the bone window images that there's almost complete destruction of the petrous bone and dilatation and destruction of the foramen magnum, foramen jugulare. So my surgical strategy, I considered it not resectable in one day or one surgical day. So I planned a stage surgery on both days with intraoperative neuromonitoring. Of course, you have to take all the measures for security of the patient in such a lesion. And I set goals. The first day I set the goal to decompress the brainstem and cerebellum, to perform a cosmetic mastoidectomy, a resection of the tumor in the petrous bone, mastoid, and from intracranially the jugular foramen, with preservation of the nerves as far as possible. The facial nerve still had function. There was incomplete palsy of the facial nerve. And of course, also from the neuroimaging before surgery, there was a very prominent V3 on the left side, on the surgical side. It was better on the other side, but this was not our surgical side. So this is the stage 1. This is my incision. You see the old incision was a straight one. This is now preparation of the vertebral artery. This is the transverse process of atlas. You see here the accessory nerve performing the cosmetic mastoidectomy. Then a drilling of the mastoids, and you see that it is infiltrated by a tumor. Then this is the intracranial part of the tumor with decompression of the brainstem and cerebellum. Despite the Avastin, you can notice that the tumor was still quite vascular. So it was, I don't know, there was no real effect. You see, this is the inner table of the petrous bone until you reach the apex, and this is the petrous internal carotid artery after resecting the tumor, and this is the fluorescence angiography with the petrous apex. So this was the day 1, and early postoperative MRI showed a good decompression of the brainstem and of the cerebellum. There's, of course, still tumor remnant in the petrous bone. There's still tumor remnant in the external auditory canal, as you can see here, tumor remnant, and of course the infratemporal tumor portion has still to be attacked, and also the external ear on middle and external ear component of the tumor. So the goal for the second day was to resect the infratemporal tumor portion and the jugular foramen tumor portion from the extracranial trajectory, to resect the tumor in the middle ear, the external meatus in the middle ear and the external meatal part of the tumor, closing the external meatus canal as a blind sac, and of course the reconstruction phase, which is very important in these big surgeries. So in order to prevent a CSF leak, and this had to be, or I did with a fat fascia lata muscle implant I taken from the right lateral thigh. You can, of course, take it also from the abdomen, subumbilical incision, so both ways are possible. I use fibrin glue, Tacozil, Duragen, and finally the bone reconstruction of the mastoid and the suboccipital part. So this is the second day. Now this is resection of the transverse process of atlas, which I already demonstrated on the first day. This is a resection of the mastoid tip, identification of the facial nerve with the stimulator at the stylomastoid foramen, then also continuous resection of the tumor which was left in the mastoid. This is the jugular foramen, the tumor in the jugular foramen. I tried to preserve the nerves in the jugular foramen, but they were very adherent and they were actually in the compact tumor mass. So this is the neuronavigation, very important in this type of approach. And this is the the tumor portion in the infratemporal fossa, which was only partly resectable with ultrasound aspirator. Otherwise, it was very hard and fibrous. So this is the lower tumor pole in the infratemporal. This is the internal carotid artery in the upper cervical part, which was very, very sticky to the tumor. And this is a resection of the tumor in the jugular foramen, now neuroinvagation. And this is through the mastoid. And you can see also it is till the tip of the petrous bone, or apex. This is the part of the tumor part in the external auditory canal, which has to be resected, and this afterwards the reconstruction phase with fat implantation and closing the outer ear as a blind sac. The anesthesiologist rushed beta-isodonna, and so I knew that there was still a leak, and this is putting a fat graft on the graft. And this is the final imaging after reconstruction. I had complications. There was a CSF leak from the external auditory canal, which required a revision 10 days after the second surgery and after failed lumbar drainage. And I had a deep wound infection, which required prolonged antibiotic treatment. But finally, both complications were solved. And this is the 3D CT scan showing the bony reconstruction after surgery. And this is the MRI, which was taken 7 months now in the last control after surgery in comparison to the pre-op. And it shows a good decompression of the brainstem and the cerebellum, and also resection of the infratemporal part of the tumor. Also, these are the coronal images, infratemporal or infratemporal fossa part of the tumor. So this is the girl at the last examination. She still had a facial palsy, fortunately not changed, incomplete. She has a good eye closure. She has a slight dysphagia, but she can swallow, so this does not pose a problem. And there is, of course, unchanged, and this was preoperative, already present 12 nerve palsy. She had no double vision, and she has a nystagmus, of course, of the cerebellar component. And this is the hypoglossal palsy. So what are the take-home messages? Of course, this is a very complex lesion, and you should always ask yourself, can I help the patient? Because this is our duty as doctors to help the patient, of course. You know, also first do no harm, so without doing harm, and you should always make a risk-benefit ratio and answer the question, would you do the surgery on your own closest relatives and beloved? The second is, in such a complex lesion, I think this cannot be resected within one stage procedure, and you have to consider a stage procedure, in this case a 2-day procedure, long surgeries actually, and you have to define goals within each stage and set priorities. So the priority, of course, was decompression of the brainstem and the cerebellum on the first day, of course. It requires a very profound study and accurate study of the neuroimages, because how to choose the approach which are the tissues and the structures at risk. For example, it's an avenues through the middle cranial fossa. She had a very prominent vein of Labbé as an very important structure which should not be damaged. You have to be very familiar with the surgical anatomy, and these are requisites for a good outcome and preserving life quality. And of course, and that's very important and often not taken very serious, the patient is your responsibility. It's not just to make a big surgery, a nice surgery. You have to be responsible in good and in bad times. So if there is a bad outcome, you're still responsible for the patient. You have to take care for any complication and do your best also on the further run and for the further course after surgery to help the patient, to be with the patient and stay with the patient and the relatives. So thank you again and for joining this meeting.
Thanks a lot, dear Professor, for this excellent presentation. Is there any question from panelists? Professor Ibrahim, go ahead, sir.
Right, thank you, Hisham, for a very interesting presentation. It's always lovely to hear you. I want just to refer to the new vogue from skull-based surgery, where the surgeon is unexperienced, and he would go for something called partial resection of the lesion followed by radiation. I do not subscribe to this practice. Do you?
No, actually, I think the radio surgery is actually postponing the complications and postponing the trouble you will get in the future. This you can consider in old patients. Maybe this is a consideration where you have several years of follow-up, and we know that there is stable disease after radiosurgery. But especially in these young individuals, I don't think this is any option. And even I cannot guarantee that the tumor does not recur. I expect that the tumor recurs because it's a vast lesion. There are a lot of cells where the tumor sticks. But I still think that now the tumor is controllable. I have created a controllable situation. And I think if there is a tumor recurrence, I would go further with another resection than with radiosurgery. This actually will not control the situation on the long run. And if you consider it first, so it makes all the surgery more complicated.
So radiosurgery is not an option, and especially so in the neurofibromatosis type 2. This is a type of pathology that predisposes patients for malignancies. And I came across 2 cases with NF2 who were treated with radiosurgery, and both developed fulminant malignant change of their vestibular schwannomas. So can you please send a clear message to young generations? Do not use radiosurgery because this is not the first option.
Yeah, I can. I think I've already done it. Of course, you know, in Germany we are using it, the radiosurgery, and I think that also Vladimir Benich also use it. I would consider it. Of course, in this case, I would not consider it. Clearly spoken. Also, in young individuals, I would be very reluctant to use it. However, there are, of course, there is a controversy in which was not the case in my presentation in cavernous sinus tumors, meningiomas. There are, you know, different opinions, and in these cases, I may consider radiosurgery because it has a good control on the tumor. But this is not this case. In this case, of course, I would not consider radiosurgery.
Thank you.
Thank you, Professor Hisham. Is there any question from panelists? Okay, thank you, sir.
Thank you.
And now we will shift to next speaker, Professor Benes. Please start sharing your screen.
Okay. Good afternoon, everyone. I hope that is the screen okay?
It's okay. Just use
Very good.
full screen. Full screen.
Very good. Hello, everyone. It's really an honor and pleasure to be here among such a distinguished faculty, and that's rather a difficult task you gave us to talk about the lessons learned. There are too many. The lecture would be too long. The first, what I have learned over the years, it's modesty, humility, respect. Because there's the Murphy law, which always tells you that if anything can go wrong, it does. And we are in a risky business and we must consider this. So we must strive, and the most important lesson is how to decrease the risk of complications. That's definitely the general rule which is necessary. And the first step to do that is the anatomy. Definitely we must know the anatomy. That's our, let's say, first goal. See this sphenopetroclival meningioma.
Dear Professor,
yes.
Please use full screen.
You do not see the screen?
We are saying it, but not full screen.
It's on presentation mode. So let me try again. Now you see all the presentation, don't you? And now
yes.
There is the...
Yes, all the slides are...
We don't see the full screen of the slides. Only the
only the things. So
single slides.
I see it properly as I should. So I'll stop sharing and do it again.
There you go. You need the presentation mode.
I was in presentation mode, John.
Okay.
So now there is the non-presentation mode, and I'm now switching for presentation mode.
Okay.
Does it work, John?
Try go slide by slide. Try the first slide. Click on that.
You mean like without presentation mode?
You don't have. Do you have a presentation mode at the bottom?
I do.
At the very bottom.
That's my screen. It's everything okay. This is the option.
Yeah, at the very bottom, there's an icon for the presentation mode.
I know, John. I really get the real and regular presentation on my screen, but you do not see it.
No, we don't.
So I do not know how I can help it. And now you see the only the MR, 5 MRs on one.
Yep.
So let me go like this. If this is now seen, so let's go in this mode.
Just try F5. F5 button.
I will try. It works. It always works. This is the first time. Let me find the F5. Where is that? F3, F4, F5. Nothing happened.
Oh boy.
Okay, let's do it this way.
Okay. That's fine.
Okay.
Do you hear me?
Yes.
It's okay. Go ahead, Sal.
Okay, so I shall go ahead like so this is the proclival meningioma which I use to do in supra-infra. This is the system of surgery. First, what I resect is the CP angle tumor. Then I the tentorium, go for subtemporal part, and then into the interpuncular system. And now I need to know the anatomy, what I'm going to see, and which structures I'm going to meet step by step during the surgery. So first is, of course, the 7th nerve, ICA, and the 5th nerve. Going further and medially, I get the 6th nerve, which I always seek actively because the diplopia is very, very unpleasant to the patient. Then going further, we are entering another system, which is ambient and crural, with the 4th nerve traversing the tumor. That's always the most difficult part, to preserve 4th nerve. And then going further into interpeduncular system, the cerebroclinoid process, you easily see the opposite side P2, the tractus and the stalk. On the ipsilateral side, again, the same structures along with the superior cerebral artery running towards us, brainstem. This is the peduncle, and always shiny structure in front of you, which is the limit of the resection, and that is the Lillienquist membrane. So keeping within the systems and encountering all the structures which are there, like the 3rd nerve, which is very clearly visible, frequently basilar artery, posterior cerebral artery, superior, and again, the shiny wall Lillienquist membrane, which is the anterior-most part of resection. And this is the whole approach. You see the V-shaped incision in the tentorium. So this is easy, but there's rather a lot of structure. So the anatomy is the paramount what one needs to know. This is the post-op image. I do not chase the tumors into the cavernous sinus. We leave this for either observation or radiosurgery as needed and as the tumor grows. Similar situation in another region. This is the pineal region. And in meningioma surgery, people tend to forget that there is velum interpositum system. The tumor enters that as well. So it's again the multicisternal tumor in ambient, pineal, and velum interpositum systems. I hope the video will work in this mode. It doesn't, but it doesn't matter. Let's go forward. And this is after the surgery, and you see again this anatomical knowledge about the velum interpositum allowed me to enter even this system that far and at the very end of the tumor and resect the tumor entirely. Another meningioma, which is like multicisternal, one should keep an eye on this part of the tumor because this is in, slipped my mind, the system above the chiasm. Again, doesn't work. But again, one after the other, and this is all. So let's go to specific and let's say cases with complications, because those are the important and interesting ones. So first, the veins. Veins are, of course, the important part of the vasculature, and somehow I do fear more by the veins than by arteries, so I put veins to the front. This is a 58-year-old female. 1 month prior to the admission, she had several collapses, and there was the EEG abnormality left frontal. This is the AVM she's having, and actually she opted for surgery, no radiosurgery, and we do not use embolization for brain NVMs anymore in the past 10 years because it doesn't beat natural course and surgically it doesn't help. What's interesting on this case is the long drainage vein, which is not ending in anus sinus, but in regular vasculature. I didn't appreciate the significance of this feature. There is a secondary draining vein going into the superior sagittal sinus. This is the video, which again doesn't work, but the surgery was very straightforward, easy, and nice. Immediate post-op angio, we do it in the same anesthesia as the resection, so this is some 20 minutes after the resection. You see that the long vein completely disappeared. There is some strange vein in the resection bed, but what's more important is that the superior sagittal sinus got occluded. And immediately at this point, one knows that something goes wrong, that there is no draining of the whole front lobe. The patient was fully awake after, but she had complete motor aphasia, very mild hemiparesis. And this is a obvious venous infarction. It grew over the 5 days. Then we lost the nerves and decompressed her. The Development was like in any other venous infarction. Over the 2 months after the resection decompression, there was slow improvement in clinical status. And fortunately, at 3 months, the patient is neurologically intact, fully normal, even with neuropsychology. This is the final image after cranioplasty. So this is something where I would like to stress that one should really evaluate all the aspects of any lesion, veins in particular, arteries probably second. So this is a rare complication, the vein nodrating into the major system and sagittal sinus occlusion. Should we have been giving some heparin early or something like that? I do not know. Probably the panelists would give me some advice. Another case, it's 20 years old female, completely healthy, severe sudden headache, strange right-sided feeling in her face, right-sided facial numbness, diminished bite force right, absent corneal reflex on the right side. This is when she came to us. There is some suspicion of multiple cavernomas, and there was the case. There were multiple cavernomas only in the right hemisphere, and the one causing clinical symptoms was located in the Meckel's cave. We dissect this, only this one. You see the cavernoma here. This is after surgery. This is intraop actually image with all the cavernomas here. But what happened after the event for surgery? There was subtemporal extradural resection. She was discharged on day 5, but on day 7 she came back with severe headache, vomiting, central facial palsy left. And this is the image. All the cavernomas in the right hemisphere bled. We didn't know why, so we went for angio. This is the MR image of those bleeding cavernomas in her right side. Another image which looks terrible. And this is the angio. Again, you see that the sagittal sinus, anterior third of the sagittal sinus is occluded. And this caused probably the bleeding of all the cavernomas. We put her on anticoagulation. We tried to reopen the sagittal sinus endovascularly, unsuccessfully. The symptomatology gradually improved. 12 days later, the recanalization of the sinus was proven. So probably due to our treatment. And the patient ended up well. You see that the sagittal sinus is patent again. So look on her. This is 1 year after. She's symptom-free, and we did the genetics. The lady has some heterozygous C677 metal reductase mutation, which is causing her the bleeding problems. That's procoagulate mutation. She has the cavernomatosis. So the question is, how far should we go with our workup? Should we consider these things prior to surgery and go really deep, even into, let's say, genetic investigation? What questions should we pose before surgery, and which of them do we need to be answered? And whether in this case there was any alternate to surgery, I don't think so. The arteries, she's a female, 15 years with one epileptic seizure, which then repeated. And she has this AVM. The nidus seems very compact. And what I did not appreciate was this red of arteries surrounding the nidus. This is the functional, all the function seems distant from the nidus. So I talked to the family, talked to the girl, and they decided for surgery. This is the angiography again. It's very fast flowing. And this is the last good image of the case, the dura opening. And then all the trouble start, everything bled. This is 6 hours spot. You see the number of clips tried when I was trying to control the bleeding, which I finally somehow managed. However, it didn't help. This is 1 day post-op. We did craniectomy. We set it out, 6 days post-op, 14 days post-op, then 6 weeks post-operative looks like this. Here we have the angio. You see that the vessels are still not in the normal shape, and the anterior cerebral is occluded. This is the image at 8 months. And this is the final image 8 months postoperatively. The girl has severe hemiparesis. She has a rather good communication. She studied some high school. She competes in Paralympic bicycling. So the final result is not really that bad, but this was my last catastrophe with the AVM, and I'm still getting awake time to time with this lady who had a name in Czech which could be translated as Miss Bad Luck. And I probably should consider even this tiny information and not go for surgery. That was definitely the mistake when I overlooked the multiple arteries surrounding the proper nidus of the AVM. Again, young girl, female, 18 years old. She's asymptomatic, coming to us with pilocytic astrocytoma. This was a extremely easy surgery. I never saw any major artery, never saw any nerve, resected the tumor. It was Friday afternoon. I was pretty confident, so I left the hospital, and 3 hours later, the resident called me that the girl is hemiplegic and aphasic. This is the CT, what it looked like. We were considering some recanalization because here already is the sign of the middle cerebral, and the middle cerebral, which I never saw, was really completely occluded. We were considering some endovascular recanalization, but considering the CT with already hypodense brain, we didn't do it, so we set it out. The girl was really hemiplegic, aphasic for quite a long time. This is the final image. There is some collateral circulation, and this is fortunately how it ended up. This is when she was in our OR, the only living creature with which she could communicate was her dog. And she's like this now with a very, very mild hemiparesis. If you talk to her longer, then you see that there is some problem, but actually she studies architecture and living a normal independent life. So I believe that we were lucky a bit because there was the occlusion of the middle cerebral at the very beginning, along with the perforators. Why did it occlude? I do not know. I have no idea. Couldn't have been spasm because I never saw the artery and carotid looked perfectly normal. Could be some other mechanism, but I do not have any explanation. I only probably was lucky with the final result. Another girl discovered NOMA. She had 3 epileptic seizures. We went for surgery. This is the intra-op. There was perfect through the inferior gyrus. Everything went well. All MEPs and SCPs went completely normal. After the last flushing of the resection cavity, I removed the retractors, and exactly at this point, the MEPs disappeared and never recovered. The girl has awoken with hemiplegia and complete aphasia, glaucoma 15. What happened, we learned only later. This is the early MR, and there is no explanation for her neurological deterioration. She was not doing well, and the explanation where we were talking what happened, here you see that there is a small infarction in the basal ganglia, and the explanation for me is that when I removed the retractors, one of the perforators must have got kinked and occluded, like the garden hose. If you break it, the flow gets occluded. That's the only explanation which could have happened. And you see that the infarction really displays the distribution of one of the perforators. At the end, she's a very, very discrete right angle instability, and fortunately, she's completely normal. And this is the last case. This is a 15-year-old boy. He's got decreased vision. When he was checked by his local pediatrician, he was sent to our department, and he was sent to our department for nearly next 2 years. So this is January 06 with this pilocytic astrocytoma, deteriorating vision. We went for biopsy, it was pilocytic. We went for surgery in May 06, resected part of the tumor, and since that time, everything went astray. 808, cyst developing, the tumor growing. This is again second major surgery. Intra-op, we were rather satisfied with the extent of resection, but it bled. So we had to go back again. And all the troubles which we all know with CSF, repeated drainages, repeated EVDs, lumbar drains. We are in June 08 now, the tumor is growing. So again, surgery, again, decompression, again, the same problems, the cyst development. So next surgery, and when on and on, the patient was several times very close to DNR order, and he was really in such a condition that even the mother asked us not to treat him too actively, to stop, because it was really like terrible. Now we are in the October of 17. It looks like that. Here is the implantation metastasis in the trigonum, but the boy is doing perfectly well. He studied some environmental studies. He now works in the Prague Zoo. He's perfectly normal. He's skiing perfectly. But he has spent with us nearly 2 years. He has had 36 MRs, 34 CTs. He was really twice close to DNR order, 4 major surgeries, repeated shunts, EVDs, Omaya, whatever you name it. Neurologically intact. He studies university. And he did study, and he has no medication, no hormonal deficiency. He's perfectly normal. The question remains, should we actually have started with the first surgery? Shouldn't we just observe and be happy with some vision deterioration, which pushed us? Probably the vision deterioration would stop at some point. Probably we could have waited, and we nearly really killed the boy, actually. Difficult to say something. So just to conclude, what one needs to know and what I have learned, it's anatomy, 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 plus behind that distorted individual anatomy by the tumor. Because say aneurysms are easy because everything is it's in normal anatomical position. The tumors may be difficult because they push the anatomy, and you must predict where the structure will be, and you must know that any structure will be there and will be moved somewhere. The most important part of surgery, in my mind, happened before surgery. It is the decision. I usually take more time with studying the images and thinking about the approach and about the modality of treatment than with surgery itself. And there is the major part of complications, because you decide wrongly. And that's unfortunately obvious only with the hindsight. You never know beforehand that you are making a mistake. You always know it after that. And after that, the mistake is obvious. Probably in the cases I have shown you, I have done several mistakes, but I didn't know them in advance. So think about everything twice and then think again. And then there is really a Murphy law. And let me now take advantage of this distinguished faculty. This is the case which came to my attention yesterday. Obviously, hemangioblastoma, the guy is 45, and the only complaint is decreased hearing loss on the left side. Anyone, any recommendation, any idea, I would just be happy. Thank you for your attention.
Thank you, sir, for the excellent presentation and most important cases that you have shared with us today, and great experience that you gave us today to learn, all of us, that we should learn, and no end of learning. And now I will open the panelists to discuss this case with you. Okay. Any comments from panelists?
I don't know. Any help is welcome. Hisham, what would you do?
He has only got some slight hearing deficit, you said?
Yes, nothing else. Decreased hearing on the left side. Normal. Looks like the singer of Metallica.
Okay.
It doesn't help.
It doesn't help in decision making. It's a complex lesion, of course. Hemangioblastomas are notorious for, and I think you can see even large vessels within the, it is not very clear, but I think there are large vessels within the within the lesion or the solid part of the lesion. So it has two components, a cystic and a solid part. It is surely a complicated and risky lesion for surgery. Maybe in this case, and after your presentation, of course, maybe we should make control first, because it's too. Actually it is a surgical lesion, but if any complication and any deterioration of the patient happens, then you will regret it. So
my thinking, yeah.
Vlad, can I make a
I don't think I
comment?
am able to resect this without harming the patient.
Can I make a comment, Vlad?
Yes, Atul, please.
No question, this is a difficult problem. No question, this is a dangerous problem. But this should be removed. And this can be removed.
At one point,
And-
I know any lesion can be removed, Atul, that's true.
Yeah,
I only was
Vlad,
amazed.
let me complete.
Yes.
You see, this is, in relationship to the medulla, as many hemangioblastomas have this relationship. And you know what, I will say, rather than piecemeal, you have to remove it en masse. You have to hold the tumor and lift it up, almost lift it up and go around the tumor and get the small vessel. Although it is quite a dangerous one, I think if
Atul, where
if
would
you are able to remove this, you will cure the. No, okay. Just say that again. Your voice is not clear, Vlad.
Yeah, I never tried to remove the hemangioblastoma piecemeal.
Yes,
What Chandra has shown, it was
Yeah.
amazing to me. I always go around, and these CC junction hemangioblastomas, to my experience, those which are dorsal have a very good plane of dissection, and they are actually extra-axial. But those who are lateral are intra-axial more. And this is the one which probably will be more intra-axial. And I'm not sure where the nerves will be, whether low, anteriorly, superiorly, where would they be moved? And this is really, I'm very afraid to go for surgery, Atul.
No, actually, this is a difficult tumor, but if you don't operate this patient, if you do not operate, then also this patient will have trouble, and the troubles will go on increasing.
Did I know?
On the other hand, if you are able to remove it successfully and despite difficulty, you can cure this person. I think, blood, you do it, and you must do it. You must try it. You must do it, this case.
Yeah, but I'm very much afraid, I can tell you. I know all this, but I was just thinking whether some bevacizumab or whatever treatment. Would anyone use radiosurgery for this? Ibrahim, you would. You are muted. You are muted, Ibrahim.
I said thank you for bringing this up, because most people think of hemangioblastoma as the cystic lesion of the small moral nodule, while in fact most of them are dangerous, especially in the infratentorial area, especially in the cervicomedullary junction. This is the commonest site for these, and thereby the blood supply would be coming from everywhere, especially from the vertebral artery, from pica, from mica, and so on. And as Atul described, that one has to go around it, and you stress the fact that one does not remove this in piecemeal. It has to be removed in one piece, as just like an ATM, you go around it and pick the feeders, etc. Still, this is a formidable lesion. Still, this is a difficult case to do, but surgery is a must. And radiosurgery, to me, I hate radiosurgery, actually. I'm against it because most people are using it, they are abusing it because they are inefficient, incompetent surgeons. There are cases where you should use radiosurgery, like Hisham mentioned, the cavernous sinus meningioma. It is well established. But to go for other lesions and take part of it and then give radiosurgery as an upfront treatment, this is a crime against humanity. So I'm against radiosurgery for these cases. They are troublesome, challenging lesions, but one should go for them and try to remove as much as one can. Thank you again for this.
Good to hear this from you. That's valuable. And Atul, I knew you will recommend surgery. I know it also. I am just afraid.
Maybe it's the timing of surgery. You probably will have to do it, but now with little hearing deficit, I think we all agree that it will have to be removed. But
we all agree on that. But you would be waiting
the timing,
for some deficit. Hisham, would you be waiting for some deficit? No. It's better.
I would control, because this, I think it's the first image. It's the first image, I think we do not lose anything with controlling. For example, after 3 months, as a first control, if it remains stable, if the clinical condition remains stable, every time you win actually without intervening, it's a win for the patient. So we don't know how this lesion will progress or remain stable for a while. So I don't think that there is now a pressure to do surgery. It's an obvious large lesion, also partly compressing. So we have to control it. Once it progresses, on either on imaging or clinically, then we feel at least more comfortable with intervening. That would be my
I was thinking along the same ways. He's 41 actually, so he will not escape surgery. That's obvious. One day it will have to be done. But probably no. Would you do it immediately, or would you follow the patients for a while?
Whom you're asking?
Atul,
No, I will do it. You know what, Blood, you will have a very pleasant surprise. It looks very vascular. It looks like dramatically vascular. But you know, there are no major large vessels are not there. There are small vessels which feed the hemangioblastoma. So you hold the tumor away from the lower cranial nerves, separate them first in the operation. They are not involved at this time. It means they are separable from the tumor dome. Separate it and gently lift it off. And with that, 1 or 2 or 3, there will not be 20 blood vessels feeding it. There may be 2 or 3 or 4, and you will find the whole thing coming out. I think giving the chance to the patient of having a normal life is absolutely, I think it should be done. Vlad, you must do it this case.
I did several of them in CC junction, and all the patients did fine. And actually, ultimately, the surgery was easier than expected. But this one is really, well, it came to my attention yesterday at Soveras. I wanted to share that with you, and I probably wanted to hear that there is no rush for surgery, there is no spot for radio surgery, and that surgery is unavoidable. And you confirmed that to me. Ibrahim?
Yeah, there is a question in the chat box saying that, is there any role of embolization? And I want to refer the person who asked to a lot of publications by George Bernard on mobilization of these hemangioblastomas, whether being in the cerebellum or in the spinal cord. It is disastrous. Most of the cases of embolization of hemangioblastoma end in disaster. So again, Vladimir, we have done the right thing by doing surgery.
Yeah, I was not even considering any embolization, because I don't like, first, the smell of the patient, and second, I don't like to move the piece of plastic, which is hard and heavy. Same as Atul, no embolization for AVMs, not for these, of course not. That's at the end of neurosurgery, probably.
No, there is no embolization for hemangioblastomas, because these are not large vessels. These are not feeding these are small, these are not multiple vessels. These are not huge vessels. They are, as you lift up the dome, you will find tiny. 2 or 3 or tiny, not 10, 20. You get the whole thing. I think it is difficult. But if during the operation you find a very dense attachment to the brainstem, then you can back off. But I don't think you will have to back off in this case. But if you have during operation very dense attachment and you have to dissect and you are having trouble in dissecting, then it is better to back off rather than dissecting.
Okay, gentlemen. Thank you for advice, and you confirm my fears.
Okay.
Thank you very much.
Okay. Thanks a lot, Professor Benes, for this excellent presentation and for all panelists to this great discussion. And now we will shift to next speaker, Professor Gerardo Guento. Please start sharing your screen.
Thank you very much. I'm going to start sharing my screen. That's it. Thank you, Professor Sameh, Professor Bennett, for the invitation. It's a great honor for me to be here with you and to share with you the most remarkable lesson I have learned from the OR. It's very difficult to select only one of them, because every time we enter to the operating room, of course, we learn of every case. But it is certainly is true that we learn more from our mistakes than from our successes. So that's why I have selected one particular case that it was a fake case that I want to share with you, but it gave me a lot of information, a lot of lessons that I want to share with you also. She was a 60-year-old female that had a long-term follow-up of 3 years, characterized by weakness, general weakness, and headache. And he was losing progressively her hearing on the left side. And then she complains about diplopia and quadriparesis. The MRI showed us this complex lesion in the petroclavian region. You can see here how the basilar artery is completely encased of the tumor. So, of course, in this particular case, I chose combined anterior and posterior transpetrosal approach to remove this complex tumor. As this is the positioning of the patient. I operated on this patient maybe 15 years ago. And as you remember, of course, the posterior and anterior combination of these two approaches is made by the posterior temporal craniotomy and mastoidectomy to perform and enter into the posterior fossa, cutting the superior petrosal sinus and the tentorium to get space by displacing the temporal lobe upwards and the cerebellum and the sigmoid sinus behind. So is in this manner we can enter retrolabyrinthine transpetrosal pre-sigmoid approach to the lesion. So see, this is the surgery. You see, this is, remember, on the left side. The cerebellum is retracted backwards and the temporal lobe is retracted upwards. Here we are the lower cranial nerves, and you can see here the tumor is a tough tumor with what's very difficult to remove with the ultrasonic aspirator. So I have to cut it and to remove it piecemeal resection. And this is the arachnoid plane, and I'm working up to the 5th cranial nerve. This is the 7 and 8. This is the 5th cranial nerve. I'm looking for the basilar artery that is here, the basilar artery. So I'm working to clean the artery by removing the tumor all around the artery. But you can see it's difficult to see here the basal. So the accident happens. So a rupture in the basilar artery happens in the transoperative period. So I put a clip only in the hole. This is a small hole in the artery. I put a clip just to occlude the leak of bleed. And this is the blood. Sorry, this is the basilar artery at the last part of the surgery and the last piece of tumor here. I could remove maybe a total macroscopic removal. I could make a total macroscopic removal of the tumor, but that is the patient. You see a lot of damage that it was caused because of the retraction of the accident that happened in the operating room, and the patient had problems with the lower cranial nerves, have increased their quadriparesis. She was submitted to a gastrostomy, to a tracheostomy, and she spent maybe 2 or 3 months at the hospital. She was finally discharged to her home, but she finally died three or 4 months later because of bronchoaspiration. So what were the lessons that I learned from this case? First of all, of course, it's very important to make a rational tumor resection. It's not a goal to remove the tumor totally. It's very important to make a safe resection of the tumor, because of course the main goal of the surgeon must be to improve, or at least to preserve the integrity, the neurological integrity of the patient. This case served me to apply to other cases, other complex cases, to make this surgical procedure with these goals. But the most important one of other lesions that I learned is that I had to check, to study, to analyze the petroclavian meningioma. So I think myself and I check all my previous cases to find if I can find something that I can produce and I can reproduce to improve the surgical removal of these complex tumors. So this information gave me the idea to analyze which approaches can be used for the removal of these complex tumors. So if you remember, petroclavian meningiomas are tumors that are growing here, exactly here, in the junction between the middle third of the clivus and the petrous apex. But it has to fit another very important condition. This is the typical case of it's a schematic representation of a typical petroclavian tumor, petroclavian meningioma growing in the junction between the petrous apex and the middle third of the clivus. But there must be another characteristic that this tumor has to fit to be considered as a real petroclavian tumor, which is the trigeminal nerve. Trigeminal nerve has to run lateral to the tumor because this nerve is displaced lateral because the tumor is growing medial to the Meckel scale. If the trigeminal nerve is not running lateral but is running medial, it means that the tumor is not in the exactly location of the petroclavian region and is slightly displaced laterally. So this is not a petroclavian tumor. So we can differentiate very clear these two kinds of tumors. If the trigeminal nerve is lateral, this is a real petroclavian tumor. But if the trigeminal nerve is medial to the tumor, it can be called as a petrous tumor, or maybe pontocerebral tumor, or other one, tinctorial, or what else. But actually, these are not petroclavian meningioma. There are several approaches that can be used for the removal of these tumors, but the most important are three of them. The anterior transpetrosal approach, the posterior transpetrosal, and the retrosigmoid approach. Of course, the easiest one is the retrosigmoid approach. So we analyzed our personal series, and we realized that most of the lesions, most of the real petroclavian meningiomas could be operated on through a simple retrosigmoid approach instead of using other more complex approaches. So if we analyze the retrosigmoid approach, what happens in the retrosigmoid approach? And this is the posterior fossa, and in the retrosigmoid approach, the surgeon displaces the cerebellum backwards. But this displacement actually is a rotation of the cerebellum around the axis, which is the brainstem, having as a radius of movement the middle cerebellar peduncle. So when the cerebellum is displaced, it gives us an opportunity to expose mostly the region of the PC angle, not the petroclavian region. But when there is a tumor here, the tumor is making some displacement on the brainstem and some displacement on the middle cerebellar peduncle that can allow us to get enough exposure of these lesions. So these tumors, the displacement that the tumor exerts on the brainstem and on the middle cerebellar peduncle can give us the information if this tumor could be operated on through a simple retrosigmoid approach or not. So these are two examples that I've shown here. Both of them are truly petroclavian meningiomas, but if you see here these tumors, if we apply the retraction of the cerebellum, it cannot be exposed enoughly with a simple retrosigmoid approach, because there is a big part of the tumor that is hidden from the light of the microscope. But on the other hand, if we analyze this tumor, also a petroclavian meningiomas, with the displacement of the cerebellum, displacement of the middle cerebellar peduncle, because of this slightly displacement of the tumor, this tumor could be almost completely exposed by a retrosigmoid approach. So the most important part to differentiate those tumors between each other and for the decision-making about the exposure of these tumors by using the retrosigmoid approach undoubtedly is the location of the tumor. As more medial is the tumor, less displacement of the middle cerebellar peduncle. As most lateral, even for a few millimeters, the displacement of the middle cerebellar peduncle is enough to get enough exposure through a retrosigmoid approach. So the brainstem is already displaced by the tumor. But if we analyze in a very particular way, the exact, the precise structure that obstructs the surgeon's view is the middle cerebellar peduncle, because the brainstem is already displaced by the tumor. But the middle cerebellar peduncle is the structure that it depends on the grade of the exposure that you can gain with the retrosigmoid approach. So if we have called this, this middle cerebellar peduncle has a pyramidal shape with a base display localized in the lateral portion, and the apex is localized in the junction with the brainstem. But if we analyze the posterior part of this middle cerebellum peduncle, the degree of displacement that the tumor exerts on this posterior part of the peduncle, it gives you the exact information about the exposure of the tumor through a retrosigmoid approach. We have called this as a peduncular line, and we have designed a specific procedure, a very simple procedure to analyze the degree of displacement of this peduncular line exerted by the tumor to decide if the tumor could be exposed by the retrosigmoid approach. I'm not going to tell you details because of the time, but we designed a protocol beginning on 2012 and finishing on 2016. We collect all the patients with real petroclavian meningiomas, and we divided into two groups. In group A, we put together all those tumors with the favorable displacement of this retrosigmal of this peduncular line, and were eligible for retrosigmoid approach. And on group B, we put together all those patients without a favorable displacement of this peduncular line, and of course they cannot be eligible for retrosigmoid approach. The only exclusion criterion was if the trigeminal nerve was found medial during the surgery. The patient was discharged for the series. We only include when the nerve was displaced laterally. So we included 20 patients. More of them were women, and with the average age of 51.05 years old. And the size of the tumor was almost 4 centimeters. But surprisingly, most of the patients belong to the group A. So 15 out of the 20 patients could be operated on through a retrosigmoid approach. This is a summarize of all the tumors that were included on group A, and you can see how this peduncular line was displaced favorably to be eligible, all those tumors through a retrosigmoid approach. In comparison, you see the group B. These tumors are bigger, are located more medially, and of course the exposure through a retrosigmoid approach is more difficult. And in those particular cases, we have to choose a more complex approaches like a combination of anterior and posterior transpetrosal approaches. About the results, a summary of the results, you can see here how most of the tumor on group A, in 12 out of 15 tumors on group A, we were able to get a gross total removal. In comparison, only in 1 out of 5 patients on group B, we were able to make a total removal of the tumor. And the final results in respect to the function, you can see how most of the patients on group A, actually all of the patients on group A could return to previous activity the way that they were doing before surgery. And in comparison, on group B, only 1 patient could return to the previous activity. So as a conclusion, we can say that the majority of patients with petroclaval meningiomas could be operated on through a simple retrosigmoid approach. And those patients particularly have a better prognostic than patients without the displacement of this peduncular line. We published our results last year in October last year in operative neurosurgery, and we are very proud that this paper was selected for the cover of this of the number of October. So with this information, we can say that with 1 failed case gave me the opportunity to analyze my personal cases and gave me the opportunity to find this new information that I wanted to share with you this time. Thank you very much.
Thanks a lot, Bo, for this excellent presentation about this interesting case and your classification and subgroup to these types of tumors. Is there any question from panelists?
Yes, Professor Ginto.
Hello, Atul. Nice to see you here.
I'm happy to see you and happy to hear you. And I want to make a few comments.
Go ahead.
Comment number 1 is, you see this petroclaval meningioma, as you very rightly said, they are medial to the trigeminal nerve. Now, when you are, this retrosigmoid approach does not mean that coming through the CP angle. Because if you are coming through the CP angle, both the 7th, 8th complex and the trigeminal nerve will be in your view. So what I had described long time ago for the first time in the literature, that petroclaval meningioma should be approached in a supracerebellar route. Supracerebellar, you cut the petrosal vein and go over the trigeminal nerve into the tumor. So your group B can also be removed by a supracerebellar approach, and you avoid the middle cerebellar peduncle because you're going above the tumor and then you're dipping down and going up towards the tentorial hiatus and other things. So this supracerebellar approach also, the other thing is supracerebellar approach is better done in a sitting position. Supracerebellar approach in lateral position may be a little bit difficult, but lateral position also, concord position also maybe, but this petroclaval meningiomas are not done by retracting the cerebellum posteriorly. Retracting the cerebellum inferiorly is the approach, and that may, tilt for maybe suitable for both group A and group B. What is your comment?
Well, it's an excellent comment. Of course, I think sometimes it's very difficult to displace the cerebellum below and to reach the lower parts of the lesion. To me, it's very difficult to reach down in the operating area. So that's why I prefer to use another approach that gives me a more direct approach to the tumor.
See, what I'm saying is, Professor Ginto, that you come supracerebellar, you come for even group B tumor, supracerebellar, and get into the tumor and debulk the tumor. And then when you have, relaxed the field, then you can come retract the cerebellum and then come between the cranial nerve. So it is not that the lower part also you have to remove over the cerebellum. You can then after a while retract the cerebellum and then come between the cranial nerves. I think, for me, I know your definition. I have read your paper. I have heard you. But my feeling is a number of group B also can be removed by suboccipital approach, supracerebellar, and retrosigmoid combined.
So you use always retrosigmoid approach. You don't use transpetrosal routes for any petroclavicular meningioma?
Not any. You see the things tumor, many of these tumors go into the middle fossa, many of these tumors go into cavernous sinus. Those tumors I would like to, all tumors, I like to do supracerebellar approach initial and then combine it with CP angle route, then work between the cranial nerves, so combined. So not in the initial route is not through the CP angle. So that is the.
Thank you for the advice. I will try to another lesson I learned. Thank you.
You must read my article on this. It was
published
some time ago. Yeah.
Can I add something? I would concur with Atul, because then you move the brain in a vertical axis and you are above everything. And the beauty of this approach is that you very early on get the interface between the brainstem and the tumor. And you know how are you going to do that. And then the lowermost part of the tumor you can easily lift, either by retrosig or sometimes from supra-infra. And it obviates the risks of petrosectomies and all these fancy approaches. And it's fast.
Thank you.
But a great lecture and great publication. I must congratulate you on the paper. That was really great.
Professor Banes. Thank you.
Okay, thank you. Is there any questions from panelists? Thank you, Professor Guento.
Thank you.
And now we will next speaker, Professor Charlie Teo. Please start sharing your screen. Thank you. Please unmute yourself.
Well, thank you very much, everyone. It's good to be here amongst friends. Good to see some familiar faces, Atul and Lad. I'm not who else is on the panel, but anyway, it's good to see you. I wasn't quite sure what Sammy wanted us to present here. So given that it was a superlative, the most remarkable lesson from the OR, I thought I'd just present my most difficult case in my 37 years of neurosurgery. And the lesson, well, the most remarkable lesson that I learned from my most difficult case. It's a little bit tongue-in-cheek, but nevertheless, here we go. Can you see my screen, Sammy?
Yes, it's okay. Just move to full screen.
Yeah, I'll move
now
to
it's
full
okay.
screen. Is it okay?
Yes, it's okay.
Yeah, perfect.
Okay, here we go. This is a little bit of fun talk. I hope you'll enjoy it. So it's my most difficult case. It was a 25-year-old girl, a university student from another city in Australia with a 6-month history of depression and progressive left arm and left weakness, left leg weakness. Her examination showed a very blunted affect. She was mostly wheelchair bound, but she could get up with a couple of people helping her and walk about 100 meters. Her MRI scan showed a massive right-sided tumor with intense vascularization, and this was the lesion. You can see that many of the vessels supplying this tumor are the size of the internal carotid artery. And not only that, there's incredible midline shift, subfalcine herniation, obliteration of all the cisterns. And if you look very carefully, you'll see that some of the scalp vessels are as big as, again, the internal cerebral artery. Okay, so she presented in that other city to a very experienced neurosurgeon. She attempted a resection and lost 2 liters of blood just with the scalp incision. The operation was abandoned after 6 hours. So it took them 6 hours just to get control of the scalp. Never made a burr hole, never made a craniotomy. And that was their incision. Not mine, that's their incision. She was discharged from hospital in that city, wheelchair bound, only slightly worse than she was pre-op. She was then referred to radiation oncology for palliative treatment. She self-referred to me and came to Sydney. I organised for a very experienced interventional neuroradiologist, Jason Wendroff, who's trained overseas, probably the most experienced in Australia, to embolise this tumour before surgery. She was admitted on at 8 o'clock in the morning to Prince of Wales Private Hospital. on May the 22nd. She was taken straight to the angiogram suite, and they spent almost 8 hours trying to embolize this tumor with only partial success. I got a call from Dr. Wenderoff saying that the tumor was extremely vascular. You didn't have to tell me that. Anyone could have told you that. And that the vessels were, not all the vessels were able to be occluded. He used a total of 26 vials of transarterial onyx, and you know that's very expensive, transarterial particles, coils. It took him 8 hours, and like I say, only partial embolization. After that 8 hours in the INR suite, she was transferred to ICU for observation. And about 2 hours later, my fellow at the time, I got a call from ICU saying the patient was unconscious with a fixed dilated pupil. He called me. I was at a restaurant across the Harbour Bridge in a place called Lane Cove, which is about 15 kilometres from the hospital. I got the call at 9:05, and I got to the hospital in 11 minutes, an average speed of 110 kilometres an hour through this business district. So you're probably wondering how I did that. Well, I was on my motorbike. I can remember the trip. In fact, I actually saw a few red lights and had to ride my bike on the footpath to get through the traffic. So it was pretty remarkable that I got there in 11 minutes, considering I was going through the CBD. We called the OR staff in urgently, and we had the patient in the operating room at 21:30. In other words, within 25 minutes of being called with a fixed dilated pupil, we had her in the operating room, which I thought was pretty impressive. Okay, so the operation started. We had 8 staff. There was massive blood loss with the scalp incision, as you could imagine. I mentioned one burr hole, but by the time I did the burr hole, she had the first cardiac arrest from hypovolemia. And she required 20 minutes of CPR. We needed 2 people just pumping blood into her just to keep her alive. About an hour later, we had 4 extra staff, again, 2 extra people just to pump blood. She had the second cardiac arrest after the skull opening. I managed to get the skull open and had 10 minutes of CPR. I called in 2 more surgeons, so that means a total of 4 surgeons and a medical student. We put the blood bank on high alert, and at this stage she had a first dose of factor 7. These are some intraoperative pictures showing just the blood bath. Essentially, there was just blood everywhere, couldn't stop anything. She was pumping blood from the scalp edges, from everywhere, and couldn't even take the tumor out, just trying to stop the bleeding. And you can see that we had a lot of people, more people now. You can see the people in the background just pumping blood in. We had the drapes off after a while because we're just doing so much cardiac massage. By the time 2, 3 o'clock in the morning came around, remember we started the operation at 9, 3 o'clock in the morning, she had the third cardiac arrest. We had 30 staff in the operating room running back and forth to the blood bank. This cardiac arrest lasted 30 minutes of CPR. At this stage, my anaesthetist said maybe we should call it quits. Her blood pressure was 50 on nothing. It was 3 o'clock in the morning. You can see me sitting there. I was just exhausted. We hadn't removed any tumor at all. The patient was coagulopathic, and we're about to call it quits. At that stage, I thought, well, listen, to save her life, we just have to get the tumor out and see what happens. So I decided to finger dissect the tumor out, pulled it out, and tore ICA, of course, the ICA off. And it wasn't just the internal carotid, there were all these other vessels just as big as the internal carotid. So a huge bloodbath. But we managed to get things under control, and an hour later, the tumor was out and I had bleeding controlled. By this stage, she had a total of 5 times her entire blood volume transfused. There's the tumor. It was a hemangiopericytoma. There's the absolute bloodbath. So the operative summary is 3 surgeons, 1 medical student, 1 resident, over 30 staff, 8 hours of operative time, 27 litres of blood loss, 96 units of packed red blood cells, platelets and FFP, 2 times trauma dose of factor 7, 3 times intraoperative arrest and code, approximately 1 hour of intraoperative CPR. She was transferred to the ICU at 06:30 hours the next day. 2 hours later, she started waking up. She was moving her right side well. Of course, she was plegic down the left side. But remember, she was almost plegic down the left side before surgery anyway. 2 hours later, she was extubated and alert. And 4 days later, she was discharged home. Hemiplegic, but otherwise the same as she was pre-op. And the post-op imaging showing a few clips, tumors out, and vascularity back to normal. So that's it. It's it was a lesson for me. I guess the lesson that I learned and that I carry with me, that it's you can be the best surgeon in the world. You can be the best academic surgeon in the world. You can have good hands, but really at the end of the day, you need a team of people around you who have the same attitude, who are behind you 100%, who you trust implicitly, and who are essentially part of you. It's a real family, I think. That work. And this is a family. We went and celebrated the win, in fact, and you can see that we had a lot of people who were part of the team contributing to this to that girl's life. There was another lesson to learn. This was the feedback that I got from the hospital administrators. Dear Dr. Teo, you have been asked to explain the clinical indications and circumstances surrounding the recent patient who required a massive blood transfusion. It has been brought to the attention of the Clinical Outcomes Committee through the Department of Haematology that an excessive amount of blood and blood products were consumed on a single patient, and that indications and timing of the surgery were questionable and possibly inappropriate. So you can imagine what I thought. I thought I was actually going to get an email from the administrator saying, congratulations, you saved a young girl's life. You did it, by amazing teamwork and perseverance and dogged tenacity. And congratulations on saving someone's life. But instead, I get reported using too many blood products and at an inappropriate time. So I guess the next most remarkable lesson from the OR that I've learned is that never expect thanks or recognition for saving. And that's it. That's my presentation.
Thanks a lot, dear friend, for this nice, remarkable lessons from Wuhan. Is there any question from panelists?
No, don't ask Atul, because Atul's going to say that he operates on one of them. He probably operates on one of them every day in India.
Charlie,
he's probably got some lessons for me.
Charlie, that was quite a wonderful and probably the most memorable case of your life. I can imagine 27 liters of blood loss is no, I can understand your hospital, the issues that your administrators faced. No matter what, you know what, Charlie, I'll tell you what, about 20 years ago, I had one tumor, this hemangioblast, we used to call them hemangiopericytomas that you are saying.
Yes.
Or we used to call them hemangioblastic meningiomas earlier, hemangioblastic. Angioblastic meningioma, angioblastic.
Yeah.
And these meningiomas, as you have seen in your own experience, like what happened in one of my cases, I was opening the skull and opening the scalp, and I lost a lot of blood. I don't remember how much I lost, but I lost a lot of blood. And the patient ultimately died. And when, we used to do brain cutting, every brain, the patient used to die, we used to do a brain cutting session with our neuropathology department.
Yeah.
And, when I went to the brain cutting, our neuropathologist just picked the tumor like with a forceps, he just picked the tumor up like this. And that was such a great learning process for me, Charlie, that these tumors, you don't mess around with the blood tumor, just hold the tumor and lift it up. And you can, there is probably not a need for finger dissection. That may be a little, but to hold the tumor and lift it up and dissect from in a quick fashion, rather than, delaying it, let the blood loss. Yeah. I think that is the learning that you must have got. And that is the learning I got from my patient, that you get the blood quickly and lift up the tumor off the base and then get the hemostasis. And once you get the hemostasis, you get the patient back. I think, Charlie, that was a wonderful case. And I can imagine the shivers and how much you must have perspirated and lost your cool during the, did you lose your cool during operation? Did you shout?
No, I don't. I never lose my cool. But I do respect your opinion, Atul, because I've seen the tumours that you operate on in India. So, you know, I actually do treasure your advice about these big ones, these big fascias. But hopefully I'll never get another one of them again.
I think I also had such an experience, not as a tumor as big as you showed, but especially in the so-called hemangioparasitomas. I think there are times where you have to switch from your microsurgical technique, which you are doing all the time. You have to switch because speed is the essential portion. So in these cases, the goal is to get the tumor out fastest. So you have to switch into the macro mood, not in the microsurgical mood.
Well, you notice, Hisham, that I never ever brought the microscope in. It was never ever a microsurgical case. So yeah, no, it was always very macro. I mean, right from, like I said, she had her first cardiac arrest from hypovolemia just with a skin incision and one burr hole.
Yeah.
So I hope others can learn from that experience. That is that, you know, you do need to develop a team of people around you who you trust, who are like-minded, who are in it for the patient, who won't argue or won't sort of give up when you don't want to give up. I mean, it was Anaesthesis who said to me, maybe we should give up. But when I said no, he goes, okay, fine, we'll just keep going. And you need that sort of attitude.
You need an excellent anesthesiologist, actually.
Yes.
That's the most important.
Yeah, very important. Very important. Anyway, Sam, I hope that was okay. Look, I'm not quite, I haven't been listening to what the others are presenting. I'm sorry it was a little bit flippant, but it did teach me a lesson, a good lesson from the operating room.
Yes, sir. Thanks a lot for this excellent presentation and discussion.
Okay.
Thank you.
Thank you. Thank you very much.
And now we will shift to next speaker, Professor Lanzino. Please start sharing your screen.
Thank you for the invitation. And when I was thinking about what I could share from lessons learned in the OR, I thought about AVMs, I think, as a good example of different lessons that learned over the years. And when we deal with AVMs, it's, you know, especially on ruptured AVMs, you start and at the beginning, you feel great about yourself and beautiful arachnoid dissection. But when dealing with the complex AVMs, it's toward the end of the procedure, at times you are faced with a situation like this. So I thought I would put together a few practical tricks that I've learned over the years and what I've learned from my teachers. And, you know, definitely you cannot stress enough when, you know, surgery, remember Vinko Dolenz saying surgery is a process. A process is made of multiple simple basic steps, and if you go through those steps, then quite often you can solve difficult problems. So planning, execution, studying the angiograms, and nowadays we have beautiful 3D models that we can pre-print. Tool has been a precursor years ago, publishing on that. And the other thing is that that's why AVM surgery is so fascinating, because it's really a combination of all the basic components that define who we are and define our specialty. When you're dealing with the complex AVM, psychologically, you need to be ready for a fight. I think Dr. Spetzler used to say there is never a simple AVM. The moment you go in and you think you're going to dealing with the single AVM, then you're not going to necessarily, respect all the basic steps that are necessary for a eventual win. Now, dealing about massive bleeding, as we have seen from Charlie's previous presentation, everything is relative. And when you're faced with the bleeding, it's not uncommon, complex AVMs. Here and there, you get stuck in a few spots where it bleeds and bleeds and bleeds. And of course, under the microscope, especially if you use the mouthpiece under high magnification, it looks massive. But just, stay calm, of course, take a deep breath. And very practical, simple thing I've learned from one of my former chairman, Dr. Elwood, is that, when that happens, just remember, it has happened before, and you have been able to deal with it many times. And paraphrasing another good friend of mine, Andreas Rabe, Andreas said, just remember everything is relative. And if you consider the bleeding that they face during liver surgery, the bleeds that we usually face in our AVM surgery are really not that terrifying. So, of course, as I said, that's like, every surgery is made of multiple, it's a process made of different steps. And there is no question that planning and executing and respecting those steps is very important. And when we're dealing with AVM surgery, it's for the most part, unless they are truly deep AVMs, complex AVMs have a superficial representation, and it's a sulcal disease. So wide opening of the arachnoid spaces and the sulci around the AVM is important. And, when we going back to psychology, this part is very important, as I said, because it allows you to get into the flow of the operation. And it's often at the beginning a beautiful arachnoid dissection, and makes you feel good about yourself and what you are doing. In this day and age of minimally invasive surgery, when it comes to complex AVMs, it's like large convexity meningiomas. There is no question that a large, wide exposure is key. Early identification of the gaining control of the feeding artery is important. And ICG fluorescence has been a useful tool, because even with experience at times in these large complex AVMs, it's not that simple to differentiate the primary feeders from some of the convoluted draining veins. So it's nice to have that immediate real-time feedback in terms of the thing. And then the dissection of the nidus is definitely one of the most important parts. We're all familiar with the circumferential dissection, being careful to skeletonize and passage vessels. But one of the tricks is that, we look at the drawings and we see these nice compact AVMs. The truth is that when you're dealing with the larger AVMs, the nidus, as we know, is irregular. And the tough part as you go through your dissection is to identify these loops that have been well described. And Professor Hashimoto from Japan has popularized the importance of recognizing these loops that really go leave the nidus and they loop around into the surrounding parenchyma, and how you have to be constant, especially as you go deeper in your dissection. You have to be constant, aware of these particular pitfalls. Another important thing, as we know, the challenging part is that how to deal with the deep perforating vessels. Those are the ones that are usually you are facing late in the dissection. When you are tired at the deep depth of the field in the EWM, because you have gone around for the most part, and it's the nidus is progressively thrombosing, so the EWM is not so easily compressible at times anymore. And if the EWM has a true conic shape and it goes to the ventricle, it's much easier once you gain access to the ventricle to get control of these ependymal feeders rather than trying to control and chase them in the deep white matter. These feeders, these deep feeders, as we know, they don't respond well to bipolar coagulation, as you can see in this situation, but they do respond well to coagulation under condition of flow arrest. So one of the tricks, sometimes like in this illustration, is to use one of those Santa microclips, arrest flow, and then a very recalcitrant feeder is much easier to control. Another thing that I learned, and I learned this the hard way, and I think it's not stressed enough in the textbook, is that there are often feeders that create a direct AV shunt, and they often are underneath the belly of the main draining vein. And again, this is one of those parts of the procedure you come across toward the end when it's easier to make mistakes. And it's also always important to try as much as possible to skeletonize that main draining vein and look underneath the belly of the vein, where often there are feeders that go directly into the vein, almost creating some direct AV shunts. So this is particularly important in the pediatric AVMs that often have this so-called linear shape around along the main axis of a larger draining vein, and therefore this process of skeletonization, and it's very important to avoid a tiny little residual AV shunt. Another thing I've learned the hard way is that, as we know, if you notice a relatively sudden swelling of the brain or change in consistency of the brain tissue, then always be aware and be afraid of a potential contained intraparenchymal or intraventricular hemorrhage. And in such cases, instead of trying to go and look around the AVM, I think I found that the intraoperative ultrasound is very, very useful to give you some real-time immediate feedback in terms of what might be going on in that surrounding parenchyma. So here are, as I said, I thought the few practical pitfalls that, about AVM resection. Some of these things are not always stressed enough, and we put this together in an upcoming publication in Neurosurgery Focus, and I used this chance to put a plug for our upcoming endoscopy and skull-based course that my colleague Dr. Seldas put together. And again, thank you for the kind invitation to be part of this symposium and this esteemed faculty.
Thanks a lot, Dave, for this excellent presentation. Is there any question from panelists?
Hi, Giuseppe.
Hey, Jay.
Hey, how are you? I just wanted to ask you, I come across some cases where I think the diagnosis of a dural AV fistula was considered, but in fact, intraoperatively, you found an AVM. So the reason why I ask is I've had a few cases of these where diagnostically it was felt by the team that it was a dural AV fistula because of a large tortuous, draining vein coming off of a tentorial area, but in fact, there was a micro AVM there. So intraoperatively, when you treated it like a dural fistula, you had that rupture, intraparenchymally and such, and so you had to change your strategy to focus on removing the AVM on the arterial side.
Yeah, that's yes. The short answer is yes. I came across similar cases, and it's often, especially for the tentorial, CP angle area, it's very difficult because some of the CP angle AVMs are on the PL surface, and at the same time, there are some dural fistulas that have a PL supply. So yes, it happens. And there are situations where based on the angiogram, there are so many tiny little vessels, feeding vessels, it becomes very difficult to differentiate. Likely it's something on the surface. So in those cases, I think that preoperative explorations, and I'm always very, very careful when I put a temporary clip in any dural fistula in that area before making the decision to go ahead and completely coagulate and separate.
Giuseppe, I want to know from you, what is your strategy of pile AV fistula? Do you use interventional procedures or you like to operate? Because what my feeling is, because the fistula, there is one large artery and then there are huge veins. The question is, if you put some on whether you like to come from the venous side, whether you would like to come from arterial side, whether there is a likelihood of spilling of material, embolic material into the veins and things like that. What is your take on that?
Yeah, a true direct PLAV fistula, I think that the main consideration is that, number one, the sudden derangement that you can cause in the local hemodynamics, number one. And number two, often they are associated with the very large venous varices. And after treatment of the fistula, that venous varix that often you don't need to remove undergoes massive thrombosis. And I've seen cases of delayed seizures and epilepsy. So I think that whenever possible, for those true direct AV fistula, PL fistulas, endovascular strategy is valid. The caveat is that to be careful, because there are some of these PL fistulas that at times might have a tiny little surrounding nidus. So I think it's very important to differentiate. In terms of the embolization strategy, nowadays there are these low profile balloons that also function as a catheter. So you can go catheterize the fistula all the way very close to the actual point of fistulization, inflate the balloon, arrest the flow, and then through the same catheter of the balloon proceed with the coiling. So that would be my preferred strategy nowadays.
On the other hand, even direct surgery, identify the feeder, just clip it. That is such a safe and such a simple strategy. You see the large artery, you have a large course of the artery always. You don't have a small course, it's a largish course. You find the artery and just clip it.
Yeah,
So
I think that's a valid strategy, but again, if you can do the same. The other thing is that some of these direct PL fistulas are more common in very young, very young children or infants. In those cases, then you deal with the potential danger of significant blood loss. So that becomes also, I think, a consideration.
Thanks a lot, Professor Lanzino, for this excellent presentation, and thanks a lot to all panelists for this pivotal discussion. And now we will shift to next speaker, Professor Roberto Herrera. Please start sharing your screen. Thank you, Professor Lanzino.
Hello, everybody. I'm Dr. Herrera from Buenos Aires, Argentina. I'm going to show you, thank you for inviting me, Samir. Thank you very much. I'm going to show you an important case in my neurosurgery life, because this case was a change in my consideration about the treatment of the gliomas. And I love the glioma surgery after this and other similar cases several years ago. I think this is not real nowadays, mainly in low-grade gliomas. I think we have to work in order to the patient with low-grade glioma be able to have more than 10 years and the possibility of be cured after the treatment, the complete treatment with surgery, chemotherapy, radiotherapy, in the cases when it is different treatments are indicated. But I think our goal will be to better these results that we can see in the books, in the papers. We are operating with intraoperative MRI mainly in glioma surgery from 2000, July 2000. We operated our first case in this operating room in Buenos Aires. Here we are checking the state of the surgery with intraoperative MRI images. And this is the case. She was a little baby, 2 years old baby, a little girl with this tumor you can see here. She was operated in another country by one of the best neurosurgeons in the world from this tumor. And this was the MRI of the baby 6 months after that neurosurgery with the excellent neurosurgeon. She was operated using neuronavigation. And I received the patient in my apartment with this tumor. Partial resection, a bad tumor because it has different areas here. It was located in central area, in motor area, in a little baby. And we had to decide what to do, if operate or not operate this baby. Both of her parents are doctors. The mother is pediatrics physician and the father is a cardiologist. And they know that with this tumor will be not probable that this girl could live more than a few years. And we decided to operate using intraoperative MRI control. We operated on February 2005, this is the patient in surgical position with not, this is the head rest, and this is the patient, little baby into the unopened MRI, 0.23 Tesla. And this is, here you can see the tumor. Yes, very difficult tumor. Were necessary 8 intraoperative MRI until we decide that the tumor was removed completely in this day, in that day. And this is the patient 10 years after surgery. Here, 1 month after surgery, enjoying the winter holiday with her family. And this is the patient 3 years post-operative with a light hemiparesia, right hemiparesia. No more important. This is the girl starting kindergarten. Here she has, she's 6 years. This video was taken 6 years after surgery. This is the girl. And this MRI, you can see complete resection on central area. This involved motor area. This is MRI, complete resection of the tumor 7 years post-operative. And here you can see February 2017. She is a girl at this time 14 years old. And this is the MRI, the same, not more tumor. She never developed more tumor. The tumor, she nowadays is completely free of tumor in this localization. This is in a wall. And I think this is the important. With partial resection, will be impossible that this girl, more than, I think, 12 years after surgery, she could be alive. Here you can see 13 years after surgery with her mother, and this is the MRI with no tumor. I think it is very important to reconsider the intraoperative images into the operating room or ultrasonography, but I think to take the possibility to check the surgery with MRI, it's a key point, very important in glioma surgery. If you remove completely a low-grade glioma, we can expect with gross total resection more than 90% of the patient very close to the 10 years pre-tumor survival. But if you do a partial resection, less than 50% of this patient with low-grade glioma will be alive 5 years after surgery, because the malignant transformation of the tumor or regrowing of the tumor. I think if we make a subtotal resection in 10 years time, we would be losing nearly 50% of our patient operated. And I think the intraoperative MRI make a big difference when we are removing the tumor. We are going to do a gross total resection of the tumor, and we have to preserve the normal area, the normal function of the tumor. I think we have to change this paradigm. We need be more we have more expectative in the treatment of our patient with low-grade glioma. And I think the main objective in low-grade glioma surgery will be the complete removal of the tumor to try to cure the patient. Of course, with minimal or not permanent neurological dysfunction, neurological deficits, but we need to remove completely this tumor, and we have to reconsider the intraoperative MRI or ultrasound into the operating room to be sure that we remove completely the tumor, or even more than the limits of the tumor than preconized Professor Dufault, the supramarginal resection of the low-grade glioma, when we can do that. I'm going to show this because we are operating a lot of gliomas, and this is our philosophy: remove completely in low-grade glioma, preserving, of course, the normal brain. But I think we have patients with more than 20 years past operated of glioma, of low-grade glioma, and they are alive completely with completely normal life and with no tumor in their MRI. I think this is our philosophy: to remove completely the tumor, preserving completely, or with minimal. In some cases, a minimal neurological dysfunction is better than a partial resection in order to preserve the life of the patient. And only for, I want to show this case, no more than this. This is my participation. I hope it could be interesting for yours. Thank you.
Thanks a lot, dear friend, Professor Herrera, for this excellent presentation. As there is a question in chat box asking about your strategy in high-grade glioma.
The same. In high-grade glioma, we practice the same surgery, perhaps more aggressive surgery. And in our experience, in most of the patients, we achieve to preserve the life of the patient near to more than 3 years in the most of the patients when the tumor is in lower location, not in midline. But doing aggressive resection in high-grade glioma, reoperating them when they regrow, I think we have better results in these patients with plus radiotherapy, plus temozolomide, of course, in oncological view of the patient. But the result is better when you remove more tumor and with less dependence of the steroids, less epilepsy. The statistics is the same. It's not the same the result, of course, in low and high-grade glioma. We have 3 high-grade glioma with complete removing of this case operated earlier in the evolution of the tumor. One of them with 8 years free of regrowth of the tumor after surgery, another with 5 years, and another with 4 years after removing high-grade glioma. But 3 years, I think we can achieve in many patients with high-grade glioma.
Okay, thank you, sir. Is there any question from panelists? Thanks again, Professor Herrera. Thank you.
Thank you very much.
And now we will shift to next speaker, Professor Cudwell. Please start sharing your screen.
Yes, I'll do that. I wonder if we can ask Dr. Herrera to stop sharing his screen. Wonderful, thank you. Well, I want to thank Dr. Samuel Morsi for asking me to be here. It's an honor, and I'd like to sort of share a sort of area that I think we really need to concentrate on, which is vascular issues with skull-base surgery. And so I'm going to show some of the things that I've learned over the years and some of the things that I've changed over the years, and show several cases. But I'd like to make the point that, you know, we need experience from surgeons that have a lot of experience, because I use this case as an example. This is a case that came in from Montana, and very extensive. This is an adenoid cystic carcinoma. And what do we do? What is best management for this patient? Well, we don't know. We don't have any grade 1 or level 1 or level 2 evidence demonstrating what we should be doing with some of these patients. And so we have to rely on the cumulative experience of senior surgeons to be able to help weigh in on the management. And I really want to acknowledge Professor Roten, who I've learned so many things from over the years, and we used to teach skull-base courses together. And then I'd also like to emphasize that I think that skull-base surgery and vascular surgery are collision tumors. They really share so many nuances. And so we've learned a lot about the arterial side over the years. And we all need to be able to replace arterial supply if we injure an artery, or if the tumor needs to be removed that's invading the artery. And we know that there's variable flow rates between some of these opportunities for replacement. So I use, obviously, replacing an artery, we use high flow grafts, such as in this case, where we'll remove the cavernous sinus and replace. You may get lucky enough in some of these cases that you may have enough room with the native artery to be able to reanastomosis, but most of the times you're not that lucky, and we'll have to revascularize. And we've learned a lot over the years about cavernous sinus surgery and resection of cases that involve this. I do feel that it's important for us to remember that we need to be aggressive with the disease before it gets to a catastrophic situation where we need to consider doing an aggressive surgery. And I think these phenoorbital meningiomas are the classic ones where there's probably undertreated initially. They're trying to preserve function, but when you know, you've got a forest fire raging, you need to be aggressive, and we'll go ahead and do an aggressive resection on that. But I think it's more nuanced than that. And here I think is a complication of radiation that's not really acknowledged as much as it should. We've published a few cases with this. This is a cavernous sinus meningioma that is now 12 years after radiation. And look at the size of the carotid artery here. And she's doing fine. She's been stable. The tumor's never grown. But then she presents with this, aphasic hemiplegic. And she's got occlusion of her internal carotid artery. And so I do think that this is an untold complication of long-term radiation. Here's another patient, 40-year-old woman, cavernous sinus meningioma. She's developing infarcts, and we need to revascularize these people. Even if the tumor's not growing, we need to think about revascularizing. Here's another patient. Look at the size of the carotid. As the tumor's grown, she hasn't had any treatment. In this case, the tumor's compressing the artery. And we need to acknowledge that. We need to be aware of the problems that can occur with that. And here's her angiogram. She's got occlusion of the artery. And we'll go ahead and do an STA, MCA anastomosis on this patient, because all she needs is augmentation of flow. She doesn't need replacement. She needs augmentation because she slowly developed occlusion of the carotid over time. So in this particular case, we'll just do a simple STA, MCA anastomosis to an M4 branch. And this will really, really help her flow. And this is a fairly simple thing. So this is my point, that we really need to be familiar with vascular surgery to be able to adequately take care of some of these complex skull-based patients. So we'll go ahead and do an STA on that. And then the other point that I'd like to make on the arterial side is that we've learned over the years about how aggressive we need to be in avoiding complications with these petroclival tumors. I think Gerardo Ginto showed a very interesting case earlier. But if the tumor is invading the brainstem, or if it's invading the arachnoid in the brainstem, there's a chance that it's parasitizing the blood supply of the brainstem. And you'll see in this case, I've left a fine little carpet of tumor to preserve the vascular supply, because if you lift off the tumor off the brainstem, you can peel the perforating arteries off the brainstem and hurt these patients. But I'd like to concentrate really on the venous system, because I think this is where we really know much less. And these are the controversies. Do we sacrifice or repair the vein or artery? What do we do with an incidentally thrombosed sinus on post-operative imaging? And I'm going to talk about that. And what do we do with radical tumor removal? Do we involve, how aggressive are we with the sinus? And radiosurgery now or wait? I think these are the things that I've learned. There's always too many arteries, not enough veins. The venous system gets more respect the more experienced you are. And the consequences of venous sacrifice are not predictable. And I think we need to, it's going to be the chore of the next generation to try and offer more information. So here's a case, for instance, invading the posterior sagittal sinus right down to the torcula. So how aggressive are you? Do you do a partial resection? Do you radiate afterwards? Do you remove the tumor or just do general radiation? Well, it's my hypothesis that we should be aggressive with these meningiomas. You can see the sagittal sinus is out, but the torcula is involved, and the transverse sinuses, of course, are open. So I'll show you what we've done in this case and how I manage this. So this is a midline tumor. So we'll do a bioccipital opening and identify the tumor. And here you see I'm cutting the falx, and we're going right back to the region of the torcula. And now I'm under the microscope, and I'll remove the tumor as aggressively as I need to, involving the sinus, and then we'll reconstruct the region of the torcula. So remember that the posterior sagittal sinus is already out. So this is a fairly low risk venous operation, because the sagittal sinus is out, it's using cortical veins, and we'll go ahead and reconstruct the torcula after we've removed the tumor. It's a two-person job. We'll remove the tumor and then identify the holes in the sinus and then reconstruct them so that we don't extend the thrombosis down into the transverse sinuses, which are both open in this case, and taking important collateral flow. So it's more complicated in this area. I think this is the most dangerous area for venous injury, and that's the falcotentorial junction. And the reason for that is because you've got to maintain the deep venous drainage of the deep brain, the internal cerebral veins, vein of Galen. So here's a tumor, and I think these are the most dangerous meningiomas that we see, in addition to petroclival tumors, but these are certainly the most dangerous ones for the venous system. So we'll do a study and we'll look and see, here's the internal cerebral veins coming around underneath the tumor. So how are you going to manage this tumor? How aggressive are you going to be? So here's the internal cerebral veins. So these need to be maintained, and you need to make sure that you offer enough flow postoperatively to satisfy the venous demand of the internal system. So here's the internal cerebral veins coming around, even though the straight sinus looks like it's occluded. We'll do this case in the lateral position, and this offers you a beautiful view without using retraction interhemispherically. And we'll go ahead and we'll take the bone flap over both sides and then lift up the dura on the inferior hemisphere, in this case, on the left side. And these tumors often separate the leaves of the falx. So you've got to cut into the falx to see the tumor, which is actually widening the falx. It looks almost normal on the outside here. And what I'm doing is I'm looking for the veins and watching where the veins are, and then we'll come around and carefully come around the perimeter of the tumor and remove the tumor and make sure deep that we don't embarrass any veins, because this is the most critical part. So what I'm using is I'm using soft cottonoids to protect the veins now as we remove the tumor. And we get across the region of where the straight sinus is. I'm very, very careful in this area and coming through and staying right on the margin of the tumor, making sure that we're not overly aggressive in this area, using the soft cottonoids to protect the veins, and then come around the perimeter of the tumor. Anteriorly here, we'll obviously, this tumor is involved in the inferior sagittal sinus, but we'll go ahead and remove this and use a circumferential technique where we watch and carefully protect the existing veins in the brain below so that we don't embarrass the flow. The remainder of tumor is removed, and then the last anterior attachment is made and cut and ligated, and then we'll go ahead and close. And we've maintained the internal cerebral veins in this case. That's the important thing. Here's the important post-op scan. You can see the internal cerebral veins. Here's an injury to the transverse sigmoid junction. And I wanted to emphasize that it's not always the venous sinus that's the risk. It can be the draining vein into the venous sinus. And of course, in this region, this is when we were doing a lot of petrosal approaches. An older woman, very stuck dura to the region of the sinuses. You've got to maintain the vein of Lebet and the superior petrosal sinus in this area. And here she is now post-op day 1, becoming lethargic after this operation, and then developing hydrocephalus. EVD was placed, and you can see now she's got a full-blown vein of Lebet infarct. So the key is here is that in some of these cases I've gone to, instead of doing a full-blown petrosal approach, I'll do an incision that encompasses this area, but do a middle fossa approach and a retrosigmoid approach to avoid this problem of the vein of Lebet and embarrassing the drainage of the vein of Lebet into the transverse sigmoid junction. It puts less risk to the sinuses. And you can see the post-op scan here. And she was aphasic for a while, but she improved, but she still has some cognitive deficit because of that. So what about some of these other cerebellar hemorrhages? This is a paper that Anna Osborne and I published many years ago now, but we have a number of these cases, and I thought about this a lot, this remote cerebellar hemorrhage, and any experienced surgeon has seen this, where you do a supratentorial operation and you have hemorrhage in the posterior fossa. And what is the cause of that? Here's a resection of a temporal GBM, and the patient's got a hemorrhage in his cerebellum. Frontal oligodendroglioma, again, hemorrhage in the cerebellum. Well, we looked at the factors, and we don't know exactly how this happens, but I have my personal theory. I think it's probably overdrainage of CSF, because I've seen it with simple PCOM aneurysm clipping, where if you drain or if you use a lumbar drain, and I think it puts torque on the veins and the tentorial veins, and they occlude, and then you get cerebellar hemorrhage of venous origin. These are the factors that predict it. Male sex, preoperative use of anticoagulation, so they may be a little bit hypercoagulable patients to start with. It's a self-limiting phenomenon, but it's something to be aware of. And lastly, I just want to talk about this because I think this is a very important point. This is I'm going to show you the results of a couple of papers that we published through the World Academy group. And the World Academy is some of the most experienced surgeons from all around the world. And we asked to share their opinions on the risk of venous sacrifice. I'm going to show you some important observations, and I think truisms over time that the senior surgeons have learned. And the genesis of this was Teet Matheson and I and Vinko Dolink. We were seeing increasing complications with venous complications, and a lot of them were in less experienced surgeons that we saw in our departments and such that didn't have the respect for the venous side as we all gain over our careers. So these are the CT studies and the MRI studies that were done that people like to use. We use MRs or CT angiography to look at the patency of veins prior to surgery. But this is a case in point. This is one of my own cases. This was a petroclival meningioma that was involving the left petrous apex, and I did a removal of the tumor. The petrosal vein was stretched over the tumor, and I just couldn't get the tumor out without removing the petrosal vein, and I did that, and they told me that I lost the potentials during surgery. And I said, gosh, you know, I haven't done anything. There was a textbook case, but I took the petrosal vein. Now, it's classically written in some of the older textbooks that you can take the petrosal vein with impunity, but I don't buy it. I've seen several complications over my career from the petrosal vein. And I think when it comes to tumors involving the central skull base, you have alteration of venous pattern and different collaterals, and you may be more dependent on those collaterals through the petrosal vein in a case such as that. And so I respect all deep veins in all of my cases, especially those ones where the meningiomas are involving the drainage of the venous sinus through the cavernous sinus and through the deep venous system, through the inferior petrosal sinus as well. So risks of sacrifice of the superior petrosal vein. This was a question that was put to the surgeons. And what you see is that there's a risk of complications that is estimated that is higher, and it's based on the number of patients that they've operated on. So the more senior the surgeon gets, the more they respect the petrosal vein. And this is a common theme for the young people. So here's a reported consequence of injury to the sigmoid sinus. And so the number of surgeons, as you get more experienced, you see more people are worried about injuring the sigmoid sinus as well. So CPA venous sacrifice. The superior petrosal vein, the mortality was considered to exceed 10% with sacrifice of the following. If the superior petrosal vein is the main trunk, is one of the sigmoid sinuses, or extensive tentorial venous drainage. So you can't always be sure if you've got one petrosal vein or one sigmoid sinus that's dominant. You may very well have injuries, and you need to think about that before surgery. And I'm going to show you some more cases about that. So this is an interesting one where we looked at the risk of handling veins in the pineal region. And so you can see that with increasing venous sacrifice, there's more increased risk of death. Obviously, this is a very critical area, as I just mentioned. So internal cerebral veins and basal vein of Rosenthal, you can see the risk of death based on these senior surgeons was high with those injuries. And if you had the number of operations that were high, like over 150, you can see how much they respected the risk of sacrifice of these veins. So the other thing that I wanted to finally talk about is the cerebral venous sinus thrombosis. And I think Vladimir showed a case earlier. I've been in and out because I'm on call today. But this issue of when you get a cerebral venous sinus thrombosis after a elective surgery, and we looked at it in our acoustic series, we had a 6% in risk of venous sinus thrombosis in retrosig and translab approaches. And what do we do with this? So here's a case example. Here's a very dominant transverse sigmoid sinus on the right side where an acoustic was removed. Look at the other side, is quite diminutive. And, she had a post-op hemorrhage and she was placed on anticoagulation. And then when they put the EVD in, they created another hemorrhage. So these are the risks that you run. And we don't have good evidence basis for any of this. But this is our protocol, and this may be controversial, but this is what we do. And this is designed to help the younger surgeons. Although many patients with postoperative venous sinus thrombosis remain asymptomatic without treatment, we've had experienced complications with untreated venous sinus thrombosis. They can be devastating with seizures, venous infarct, or even death. We heparinize if it's the dominant sinus or if the other side is very, very diminutive. And we want to document that the sinuses connect at the torcula. So you look at this at the studies and make sure the torcula is open. If this postoperative sinus thrombosis is symptomatic, it's treated with anticoagulation unless there's a matter, regardless of dominance. And therapeutic low molecular weight heparin is avoided in the early postoperative period. So patients unresponsive to anticoagulation demonstrate therapy. We then use more aggressive measurements like intraoperative or endovascular treatment. And oral anticoagulation or therapeutic Lovenox is used for a 3 to 6 month period in those patients. So if they're symptomatic or if it's dominant sinus, we anticoagulate them. So in conclusion, we do not have the same knowledge of veins as arteries. There's much variability. There's no quantification that we have. You can only really look at the studies, the venous studies or the angiogram and determine what the venous drainage is. I warn people that you've got risks to the central skull base when you have meningiomas involving this area because the venous drainage can be altered and you may be more dependent on some veins that you wouldn't expect to be so important as they would be if there was no pathology there. Experienced surgeons have much more respect for veins as they age, and we need better techniques to understand collateral flow. And I think this is the area that we're very interested in trying to quantify what the venous drainage is to try and avoid some of these devastating complications. So I'll leave it at that, and thank you very much.
Thanks a lot, Professor Caldwell, for this excellent presentation and for notice that you have gave us today about this important issue. Is there any question from panelists?
Bill, that was excellent talk. I really enjoyed it. And I echo your sentiments of cerebrovascular and skull base, being collision tumors and going hand in hand. My question is, we've seen a run of these carotid occlusive diseases in like what you showed with the cavernous sinus meningiomas, and I just got a patient yesterday actually in one of my squamous cell carcinomas I resected endonasally that had radiation treatment, and I assume they radiated the neck as well using a head and neck protocol, and he presented with an asymptomatic incidental carotid occlusion on the post-op MRI surveillance scan. So my question is, what is the timing of revascularization if they're relatively asymptomatic or they haven't had any stroke or TIA events yet? Do you wait till they have a clinical event, or do you have some kind of vascular study, or do you preemptively do an ECIC on these carotid occlusions?
Yeah, I mean, that's a good question, Jim. I think most of the time you get away with it because when the occlusion occurs, it occludes slowly over time. And I think that what happens, it's not surprising that you get occlusion in some of these patients. And I actually have an interesting series of patients now we're just publishing with aneurysms of the cavernous sinus after radiation because it's so common to be radiated there. But I think what happens is you get fibrointimal hyperplasia like you do when we treat AVMs, obviously, is the mechanism. And so it's not surprising that we're losing some of these carotids. What I think is that we don't really have a handle on the real risks over time with these radiation treatments. And they occur in a delayed fashion, like that one lady I showed you that was, 12 or 14 years after radiation of her cavernous sinus. So what I've done is if they show any signs of symptomatology, we'll do an angiogram, we'll do a CT perfusion and see what the reserve is. If the reserve is bad, then we'll go ahead and do an ECIC on them. And usually those patients just need a SDMCA, as I mentioned. If we resect, obviously, the tumor in the cavernous sinus and we replace it, and when the carotid is still open, then we'll use a high flow bypass. But I haven't done asymptomatic patients, Jim. I've only done symptomatic ones. But I just call that to everybody's attention because I think that people freely radiate that area And we don't always really understand the real long-term risks, especially on these younger patients.
Okay, thank you. Is there any other question? Thank you, dear friend, Professor Goodwill, for excellent presentation. And now we will shift to next speaker, Professor James Leo. Please start sharing your screen.
Okay, can you see my screen?
Yes.
Okay, great. Thank you, Sammy, for organizing this great educational event. I'm just going to show a few potpourri of cases where I've learned some important lessons in my career. I'll start with the first case. This is a 54-year-old female who presented with headaches and seizure-like symptoms where she complained of sleep paralysis, otherwise neurologically intact, but she had this looking scan here. You could see large flow voids, a very thickened falx, and this large varix near the inner hemispheric fissure. It enhances on contrast MRI, and you can see the location of it is largely inner hemispheric with a large varix here hanging from the falx. So she had an angiogram. This is the internal carotid injection. You could see, I'll show you some more cuts. You could see it's filling this large tortuous varix. Again, this large tortuous varix going into the vein of Galen's system, dumping into the transverse and sigmoid region. But on the external injections, you could see these large caliber external feeders feeding the falx and dumping into this varix. And these external feeders are as large as a carotid artery caliber. And you can see it's feeding from both sides and from some ACA feeders here and external feeders from the other side, and then some feeders from the posterior circulation. So she hasn't bled, but she has this large venous varix coming off of the falx and feeders going right into the falx. So the question, this is a CTA showing the same thing. You see large varix here. So the question here was, what is the diagnosis? And this case was discussed amongst our team, and several of our endovascular colleagues thought that this looked more like a dural AV fistula, dumping, feeding into the falx and then exiting from the falx into the vein of Galen complex. The case was actually passed around to several well-esteemed colleagues around the country, cerebrovascular teams, and again, it was largely felt this was a dural AV fistula. And so, the question is, how do you treat it? And if you went into this case thinking it's a dural AV fistula, your strategy here would be, embolization either transarterially or transvenously, and pushing the glue material into the venous side. So, I went in thinking it could be an AVM. Maybe it was a dural fistula, but I felt that perhaps, we should explore this and go at it surgically and, be ready for either diagnoses. So she did have embolization of those distal ACA feeders preoperatively, and unfortunately she did have a mild stroke from that first stage embo, but she recovered. But after multiple stage embos of both internal and external feeders, we decided to come in interhemispherically with the left side down. And here's the video. This is a nice approach using gravity assistance, and you can see the falx is very hypervascular, and here's some embolic material in the distal ACA feeders. You can see the arachnoid's quite thickened, and then there's the beginning of the venous varix coming out of the falx. There's a hypervascular mass here coming from the free edge of the falx. It kind of looks more like an AVM here, so I'm just carefully devascularizing it stepwise, looking for each feeder, identifying each one and following it into this nidus. And as we work around it circumferentially, you can see there's some more embolic material here. We're coming around the lateral component. Here's some embolic material feeding. And then here is the draining vein. This is the tortuous venous varix here. And we're dissecting it to isolate it. And here I was still thinking, could this be a dural AV fistula? So I was preparing to put a clip on here. And then here's the draining vein. And I can tell you when I put a clip on here, blood immediately came out of the top, the superior sagittal sinus from venous pressure. I quickly took the clip off, and I had to wait about 30 minutes for the brain swelling to come back down. Once the swelling came back down, I realized this is an AVM, and then I began to resect the falx, thinking that the AVM was inside the falx. Now, as I'm devascularizing the falx, I get into some heavy arterial bleeding, and very difficult to control here with clips or bipolar. And this is one of those moments I think Giuseppe mentioned earlier when things kind of go bad out of the blue, and this is where the fight begins. So I just pack it off with gel foam here and some cottonoids to get some control. The bleeding is so significant that it overwhelms the bipolar's ability to coagulate. So how can you create a situation where the bipolar now gains advantage? So we gave some adenosine cardiac pause, about 3 runs of this, and this gave me enough time to get some control, but it really didn't help me until we were able to pull the tray that had the angled bipolars, because straight bipolars doesn't give you the proper angle to coagulate this falx. And so finally, when I got the angled bipolars and got the falx under control, I was able to then proceed with the rest of the surgery. And now that we have bilateral parafalcine control of this parafalcine AVM, we can now come around it circumferentially, take out the last bit of the arterial feeders, and then come around the falx towards the back. Now you have to be careful as you come around the back side. You can, if you overshoot, you'll end up in the vein of Galen complex. So keep your orientation as you're resecting the falx. And then we're peeling the AVM now off of the corpus callosum. You can use the corpus callosum as a guide. It's got a nice white color about it. And then now we come back to the draining vein and then isolate it. And then we're cauterizing the last bit of the falx. So here's the draining vein, and I do the pinch test. But look, when I pinch it, the draining vein, the AVM swells. And that's important because that tells you that you have not completely devascularized the AVM enough to take the draining vein. So using that little pinch test is a nice, helpful strategy so that you don't prematurely occlude the vein and get into some torrential AVM rupture. So I then explored, devascularized more falx, and now you can see when I do the pinch test, there's no bleeding. So now it's safe to go ahead and apply your clip to the draining vein. There's no changes in the potentials. And now we can disconnect the AVM from the draining system and then remove the remainder of this. And there's the last portion of the AVM removed. And so this lady underwent a complete resection. Post-operative angiogram was normal. and she made a very nice recovery. She was neurologically intact with some mild weakness from her embolization stroke, but she continues to improve with time. So I think the lessons learned from that case was you really need to know the accurate diagnosis. So if this was treated like a dural AV fistula, and if it was done endovascularly, I think in retrospect she probably would have died on the table from a massive hemorrhage. So I'm glad that we went in there and explored this surgically. And the other lesson I learned was that you need to have enough arterial devascularization before occluding the draining vein, and using the pinch test is a good litmus test. And then adenosine arrest is also a useful strategy when the vascular control of the bipolar is overwhelmed by the bleeding. So slowing down the heart certainly helps. The second case I want to show is this female with this large petroclival meningioma. You can see the features of this meningioma are such that there's Meckel's cave involvement, and there's a good component of supratentorial involvement and hydrocephalus. And so our strategy here is, of course, getting a maximal safe removal. We've heard talks about retrosigmoid approach, but I feel that here retrosigmoid approach would be too much excessive cerebellar retraction, and you can see how the cerebellar peduncle wraps around the back of the tumor. You can consider various pre-sigmoid or anterior petrosal or even combined petrosal approaches. And what I've chose to do was a combined anterior petrosectomy with a transcrusal approach where you remove the superior and posterior canals, and this really gives you that extra space. And by removing that superior canal, you don't have this inhibition of your line of sight subtemporally, which it can often do, and you can still preserve some degree of hearing. I often will use the endoscope at the end to look around corners, to look into Meckel's cave, and we recently published this video in Neurosurgical Focus that you can find. We'll do this through a left petrosal incision, and we do it in stages. This one I did in 2 stages, with the exposure on the first day and the tumor removal on the second day, especially for a long case like this. So here's the anatomy on the left side. We're doing our retrolabyrinthine petrosectomy. Here's the otic capsule. You can see the semicircular canals, Trotman's triangle. And then we'll go ahead and drill the anterior petrous apex and combine it with a Kawase. And I think what this does is this really gives you multiple variable angles of attack. You can come at it anterior transpetrosal or come at it pre-sigmoid, and you have a lot of different options and angles of attack, and it really widens your exposure. So here's the otic capsule, and we'll go ahead and take down each superior and posterior canal, and as you're drilling it, you need to wax off the ampulated ends to prevent loss of the endolymph, and that's what helps preserve the hearing. And if you use a suction irrigator, it'll flood the field so you don't lose that fluid. And then this is at the end of the exposure. Here's the facial nerve, and you can see a wide exposure. We'll close and then come back second stage for the tumor removal. And so here is the vein of Labé, but look how it's in the way. So one way to get around the vein of Labé is you cut the tentorium around it, you preserve the insertion of the vein to prevent that dreaded vein of Labé infarct, and then you can ligate the superior petrosal sinus, and then slowly open up the tentorium, and it gives you incremental exposure of that tumor from the infratentorial space. What's nice about this approach is that when you cut the tentorium, you really help devascularize the tumor. So by the time you've ligated the tentorium, the tumor progressively becomes softer, and then you can peel it off of the brainstem. Here's the 7th and 8th nerves here. Here's the brainstem. Here's the root of the 5th nerve on the brainstem. It's being pushed downwards towards the 7th nerve, and then using sharp dissection we'll continue to peel the tumor off, and then we'll start to see the basilar artery on the medial side. And the 6th nerve is always the hardest to see. It's always the last nerve at your end of your exposure. So beware of where the sixth nerve is. It can be easily injured. But what's nice about this approach is that I feel that you get a really short distance to Meckel's cave. You can open up that tentorium right into Meckel's cave and then fish out the tumor that's in Meckel's cave. And I think being able to open up Meckel's cave is a nicer approach to the alternative, which is the RISA approach, retrosigmoid intradural suprameatal approach. And then lastly, we'll come subtemporally and find the superior portion of the tumor, which is now very soft, and you have to find the fourth nerve. This is the nerve that tends to be very vulnerable in these cases. You can see it's wrapped around the tumor, so you really need to sharply cut that arachnoid to release the tumor adhesions from the nerve so that you don't injure it or avulse it. If you do injure the fourth nerve, it is a nerve that can be recovered. So if you do injure it, find both ends and put a single suture, and often that nerve will recover. And so here's the last component of it, bringing the tumor down. Again, the tumor has become very soft sequentially with time. And then lastly, we'll check with an endoscope and inspect all the nerves here. And so we left a little droplet of tumor on the trigeminal nerve rootlets where it was adherent. And, oh, sorry, I don't have the post-op scan, but she did quite well neurologically, and we had a gross total resection of the tumor. And then lastly, I wanted to show this large MCA rupture. This was treated in another state with endovascular coiling, and I think MCAs are aneurysms that can be occluded and potentially cured microsurgically, especially with these large, complicated configurations. But with large aneurysms, we know coil compaction has a higher risk, and this recurred. And so now she's got a recurrent aneurysm with coils. And so what are the options? We can explore, we can try to reclip it, maybe bypass, or sometimes in this case, you have to extract the coils. So here's the exposure of the neck of the aneurysm. This is the M1, and these are the two M2s. You can see it's a wide neck. There's calcium in the neck. And so what we'll do is we'll put a temporary clip on M1, and I'm going to try to clip it as my first option. And so you can see what's happening is the clip blades now slide down and occlude the MCA bifurcation, and it's because of the coil mass. The coil mass is forcing it. So my next option is I'm going to trap the aneurysm and open up the aneurysm and debulk the coils. Now, you should always have your CUSA ready and test it before you do this, because you don't. The last thing you want to do is you're shutting down flow to the brain and your CUSA is not working, and so that's a bad situation. So make sure the Sonopet or the CUSA, the tumor aspirator, is working, and then you go ahead and commit to opening the aneurysm and occluding both M2s to the brain. And you have to work efficiently. And so you do enough of a thrombectomy to start to reconstruct the aneurysm. And so we'll use a fenestrated clip here using tandem clip technique because you have higher closing force on the fenestrated clips. And then we'll remove the temporary clips. And what we're doing is we're insunating the MCA vessels, but look at this vessel, it's blue. There's no signal here, so I know this M2 is occluded. And so what do you do now? Do you leave that there? How do you get this M2 to open? Well, you need to reopen the aneurysm again and get backflow from that M2. So I'm going to temporarily clip the M1 and the other M2 and then reopen the aneurysm to see if there's any kind of debris or flap of dissection occluding that lumen. And now I'm getting backflow. And I want to get good brisk backflow, make sure all the debris is gone. And so we're going to do a little cleaning up of the lumen with a little endarterectomy with scissors, clean off the debris, and then irrigate with heparinized saline. You can see the lumens are now nice and smooth. And now we're gonna redo our clip configuration. And the key point is that you don't want to clip it perfectly extraluminally. You want to leave a little bit of redundancy or remnant, because what you see on the outside doesn't reflect what you see on the inside, because there's calcium and thickened walls. So if you clip it too perfectly on the outside, you may be stenosing the bifurcation on the inside. So once we've finished the clipping, we now have time to, we've restored flow, so now we can take our time to remove the rest of the coil mass and then finish our tandem clipping with a little reinforcement and finish here. So, you know, the lessons learned here are, you know, if you have an arterial occlusion, you really have to, you can't close and go to angiography and figure out how you can open it. You have the head open, figure it out, open up the aneurysm and get some back bleeding before you finish your case. So I think that was the important lesson learned here. And don't go for the perfect clip. You have to leave a little redundancy on these thick walled aneurysms. Thank you very much.
Thanks a lot, dear friend, for this excellent presentation. Is there any question from panelists?
I have just one comment to your last case. I think that the fluorescence angiography has a major role in this because you can nicely see the blood flow in both M2s and the complete clipping. So you have also the view, the external view of your internal condition. I think it has a good role in this.
Yeah, I fully agree, Hisham. I don't think I showed it in the video, but yeah, it's a good technique to have.
Thank you very much.
You know, with respect to that, Jim, one of the problems with those calcified aneurysms is when you do ICG, you don't see the inside of the aneurysm that well. I think that's the problem, right? Yeah.
Yeah, that's true.
Yeah. Jim, we have actually published a case that was very similar to your first case with that dural fistula adjacent to the AVM. And I don't know how that occurs embryologically, but I appreciate your insights into that.
Yeah, that's always a tough one. I mean, these are tough cases to decipher. I don't have a great theory, but I think, you know, that vein is a sump, and this one was recruiting arterial feeders from both extracranial and intracranial. And I think if I go back and look at that case more carefully, there is a hint of a nidus on that internal angiogram run. There is a bit of a nidus right at the distal end of those pericallosals before it dumps into the venous varix. But I think if you look at the external runs, you can be fooled thinking this is a dural AV fistula, and I think that's what a lot of my endovascular colleagues kind of got swayed by with those external runs.
Yeah, it's interesting because our case was exactly in that same location, Jim. And I'm wondering if it's something to do with if you have an AVM in that location, whether the high venous pressure is somehow involved in the genesis of a dural fistula adjacent to it. And that's why but I appreciate our opinions on how that can occur. Thank you, Sammy.
Okay, thank you, Professor Leo, for this excellent presentation. Thanks, dear panelists, for this great discussion. And now we will shift to next speaker, Professor Maria Silda. Please start sharing your screen. Thank you, Leo.
Thank you very much for this invitation. It's an honor for me to be here. And I'm going to share, you know, I think that given my background in surgical anatomy, I figured I would share a little bit of some details that I think that are important to look at during surgery, especially for the younger members in the audience and trainees, because I think one of the most remarkable lessons in the OR that I think we've seen and we are learning every day, at least I'm learning every day, is how can we prevent the event? How can we think? And anatomy is essential, especially in our field. I'm discussing specifically skull-based surgery, how we can anatomically think beyond the case. And this is something that comes to how to prevent an event, and also about the fact that you are never, I feel like we're never too well prepared for the case. There can be always unexpected situations, and we should be able to take different roads as needed to avoid complications. And so for me, surgical learning and surgery is a balance between the controlled environment, which is what you can learn, the spatial orientation and the X-ray see-through vision that Dr. Roten really emphasized, what is behind our tumor, what is behind the plane that we are dissecting in that moment. And then the learning through repetition of procedures and steps that goes not only with dissections in the surgical anatomy lab, but also with experience in the OR. And what I think is something that we can't emphasize enough is to look carefully at the preoperative studies. What are the anatomical variations? What is this distortion of the anatomy in the particular case? And where are the key structures for every single case that we do? And then we have, it's never 100% controlled environment. We have non-predictable events, and we have patient variables. So my approach to every case is, how can we dissect the case? How can we look at the preoperative studies and reflect on the surgical anatomy of the case before even getting into the operating room? So anatomical variations, be flexible to change the plan accordingly. What can be behind the scenes, what is behind the exposure that we are going to have. And as Dr. Roten said, only expose what is essential to the operation, leave what is not essential to be exposed. For the surgical anatomy lab, we need to know that is there, and also respect the arachnoid planes. That cannot be emphasized enough. So the systematic approach that I try to follow and I try to teach the residents and fellows is, what are the anatomical variations? The key anatomy for the case, including bones, the arachnoid planes, the arteries, and the veins. So for instance, in an endoscopic endonasal case in a CT and CTA, I usually get CT angiograms for almost every case of skull base that I do, either endoscopic or an open approach. And here in this dissection, we can even see different anatomical variations. For instance, in this one, we have an anodic cell, which is the most posterior ethmoidal cell, and this is present in about at least 30% of the cases. We have a sphenoid sinus that is not completely pneumatized up to the skull base. And what that means is that we are going to, if we do an endoscopic case and we are treating, for instance, tubercle meningioma in this area or any sort of supracellular case, we're going to have an image like this. After performing a posterior ethmoidectomy, we see that the optic canals are within our view, but we have not opened the sphenoid sinus. So this can be a minimal anatomical variation, but it's very important to know before we get into the operating room, because thinking that this behind here we have still sphenoid sinus can lead to a major complication. So this is how we see the usual sphenoid sinus. We are going to look at the variations in the CT regarding the sphenoid septations that are also very good guides, because if we know exactly where they are in the CT scan, we can orient ourselves to where the carotid artery is going to be in case our sphenoid sinus is not completely pneumatized. And then we have to really look behind the scenes. And what that means is we are going to expose maybe just this part in this operation, but we need to know what is behind our exposure. We need to know the distances, for instance, in an endoscopic case for the trainee, it's very important to know the distances between the supraclinoid carotid in case we are going to approach a supra diaphragmatic pathology here. What we have, what is our working distance, and or in case of a transclival approach, what is the distance between both carotids? It can be variable. And also, if we are going to the odontoid, for instance, knowing the parapharyngeal carotids, the distance between them is also very important. So when are we going to change the plan? So for instance, in a case like this, where we have, this was a meningioma grade 2, a patient who his mid-50s that had progressive visual loss, and we were facing with these tumors. So the anatomical configuration that comes into mind is a pretty complex array of neurovascular structures that we need to systematize and look at the bone, look at the arteries, and look at the veins. So in this case, we proceeded according to plan, performing an orbitozygomatic approach, anterior clinoidectomy, opening and dissecting the structures. And this is the final view after removal of the tumor, filling the cavernous sinus and removing the gross total disease. But sometimes we can have different anatomical variations. For instance, we have to look in the CT scan at something that I think is very important and sometimes is not really looked for, would be a middle clinoid or a carotidoclinoid ring. And what that means is that either if you are doing an endoscopic approach and you are around the middle clinoid, or you are doing an anterior clinoidectomy, if you have a solid ring around the carotid, you may want to just drill up to the tip of the clinoid and try not to break the clinoid, trying to get the tip of the clinoid completely, because that can potentially injure the carotid artery. So this is the configuration of the anterior clinoid and the middle clinoid around the carotid. If we have a ring, like for instance, in this case, this is a sphenoorbital meningioma, a patient in the mid-40s who had proptosis and progressive visual loss. And here we have a carotidoclinoid ring. We can see the upper part of the ring and the lower part of the ring. So in this case, and this is the configuration of the clinoid, we were quite happy to just leave a couple of millimeters of the tip of the clinoid that we're anchoring the here to the middle clinoid. So I think that's a minimal change in our surgical plan that otherwise had a gross total resection, but I think that's something to have in mind. Another question about preoperative planning is also to look at how the calcification of the arteries, if the patient has calcification of the arteries, we need to be careful also manipulating those arteries when we do the dissection of the tumor. And here we can see that what we can see in the preoperative scans, really, we can see a big atherosclerotic plaque and calcification. So that tells us that we have to be very careful manipulating this tumor when we perform the resection. Another key point to have in mind is the arachnoid. I think this is a fantastic paper I think is a must read for all the neurosurgical residents and fellows, that the arachnoid and the cisterns are extremely important to know. And I think that's very important because we may or may need to open into all the arachnoid cisterns that are around the tumor. So what that means is that I try not to open the arachnoid cistern that is not involved into tumor. And the reason for that is because unless you need to release CSF or do another maneuver, if that arachnoid cistern is not involved in the tumor, sometimes it's very tempting to just open and expose the beautiful anatomy that we have in front of us. But I would say, as Dr. Roten said, expose what is absolutely necessary for the operation. And that because that arachnoid will protect the structures and will protect the cistern from blood during the operation and other problems. So what we can see here, and a lot of the times our dissections don't show accurately the arachnoid cisterns, but I think it's very important to know how they are distributed and how they are localized anatomically. So this is a view endoscopically. So this is the sella and this is the supradiaphragmatic area. And we can see that this is the outer arachnoid. And in small tumors, we can see that these outer arachnoids, especially in planomeningiomas and sometimes tuberculomengiomas that affect and cause visual loss, some of them, they still have part of this outer arachnoid that is preserved. If we open the outer arachnoid, we are here in the chiasmatic cistern, and then we gradually will go to the carotid cisterns laterally and the interhemispheric cistern superiorly. But this is very important because in some tumors like this is a tumor where I elected to do a subfrontal approach for resection. I know that sometimes most of the times in the posterior aspect of the tumor, there's an arachnoid membrane that is part of the outer arachnoid that protects also the chiasmatic cistern. So unless there's tumor invading that cistern, I try not to open it unless it's absolutely necessary. And so I think that protects also the chiasm and the chiasmatic branches that are extremely important. So for instance, this would be the view with a subfrontal approach. And what we don't have here represented is the arachnoid. There's a nice layer of arachnoid here that very often in tumors that are not too extensive that go posteriorly and push the diaphragm superiorly and posteriorly, you can find a lot of the times an arachnoid that is protecting these structures. So for instance, in another case like this, it's important to notice also in the preoperative CT scan, all the details. And what this tells you, and in this case, I particularly chose to perform a frontal orbital approach for resection of this. Ended up being a grade 2 meningioma in this area and a smaller grade 1 meningioma in the other side. So looking at the configuration of the frontal sinuses and also looking at the configuration of the thickness of the bone that, gave a little bit of extra time for the craniotomy because we had to actually trough the craniotomy. I think we were able to not enter the frontal sinuses. So every time that we respect an anatomical structure, performing the work that we need to do and removing, performing a maximal safe resection, gross total resection in this case, if we avoid entering structures that we don't necessarily have to, I think that progressively diminishes the possibility of complications. So then what about the vascularization patterns? I think for me, at least in my practice, it's very important to study the preoperative CTAs for any tumor that also show the venous flow. So with that test, I have quite a good idea of the variations of anatomy. For instance, you can sometimes have duplicate vessels, that's this duplicated SCA. And other here, apart from this, there are other vascularization patterns that are too small to be captured in preoperative CT. And then is when we have to really pay very close attention to how we manage these vessels that we often don't see very well. We see them very well during an endoscopic endonasal approach many times, but they are critical to provide vascularization of the inferior part of the optic chiasm. And I think that's how a lot of the complications from tumor growing in this area and removing the tumors from this area happen as far as worsening vision or visual loss after surgery. So for instance, in a tumor like this, the key critical anatomy is going to be the vascularization of the optic chiasm, in my opinion. And this case, we chose to perform an endoscopic approach. Also the same critical anatomy in this case and the supraclinoid ICA. And I would add here that also the critical anatomy in that case is the pattern of the ophthalmic artery. And that we can see also in the CTA to some extent. So there are three patterns of ophthalmic artery. This is a paper by Dr. Agosti in the lab. So one is the initial segment of the ophthalmic artery can be quite anterior and inferior. And then the second pattern is inferior to the optic nerve. And the third one, which is more infrequent, is just inferior and a little bit posterior to the nerve. So these are the vascularization kind of relationship patterns between the optic nerve and the ophthalmic artery. And what that is relevant for is for tumors like this, in which after removing a small tuberculum meningioma endonasally, we want to remove this part of the dura. So we have to pay close attention to how the ophthalmic artery is located and where it's located, because if we need to open the dura of the optic canal further beyond this point, we want to open it in the superior third of the optic canal, not to damage the ophthalmic artery. And all the time, every time, if we put the Doppler here, we're going to hear a signal, a vascular signal that this is not the carotid artery itself, because it continues here, but is the ophthalmic artery that here is ventral and towards us. So for instance, in tumors like this, we many times want to get all our different tools for preoperative planning. And this is a 3D model performed after the angiography. This is a young patient, 40-year-old with that developed hydrocephalus, had a shunt placed in another institution and came to us for resection. And the angiography showed a very vascularized lesion. And this is the distal pica that was able to be embolized, so had a partial embolization of the lesion. And this is just to show how important it is to have a good understanding of the anatomy. So this is a far lateral approach that we perform for this case, in which we can see that the anatomical picture and the surgical picture really have an extraordinary correlation. So we can identify and follow. We know that there's going to be pica loop here at some point deep to the tumor. And here is going around this lesion that ended up being a hemangioblastoma. Here, after coagulation of most of the outside of the tumor, we could finally divide it in two, and then removing this half part of the tumor, which was quite large. And then after that, removing the last bit of the tumor, and coagulating all the feeders, trying to get around the tumor to avoid the bleeding, because it was still quite vascularized despite the embolization could not be, was not deemed to be very safe to embolize further pica because of the, was feeding important parts of the brain. So here we are seeing that pica comes into view in the loop, and this is just to demonstrate that our anatomical correlation and our surgical correlation is very, very similar after resection of this tumor. The patient ended up doing really well, and this is the postoperative result. This is 3 months after surgery. And then the last part of, I'm just going to touch very briefly on the anatomical significance of the veins that has been discussed extensively, and here are the veins our allies or are our enemies? So I think they are allies when we preserve them, and they can be very bad enemies when we don't. And trying to go to the key part of the venous anatomy of the pathology is extremely important. In this particular case, the superior sagittal sinus was occluded here, so we divided all of it and took the tumor out. But this vein had to be dissected and was critically important for preservation of function. The patient did very well after surgery. And this is another, and Dr. Caldwell really explained beautifully the significance of the veins, but I think we should preserve as many veins as possible, and the significance of the sacrifice of the petrosal vein, significance of the sacrifice of the vein of Lavey and the sinuses, try to preserve as many venous structures as possible, I think is critical. And especially also the internal cerebral veins, the vein of Rosenthal, are extremely critical structures. And I would like to finish by just reiterating to expose what is essential for the operation, to perform the goal of the operation, that is the maximal safe resection and gross total resection if we can, and respecting the anatomical structures, and that this surgery requires, and each patient deserves your concentration, your study, your attention, and we are there for the patients, and there's really no final frontier for the study of surgical anatomy, as Dr. Rotem said. And I just would like to acknowledge my team of fellows and colleagues who have supported me and the work in the lab. And thank you very much for your attention and the kind invitation.
Thanks a lot, Dr. Zelda, for the excellent presentation. Is there any question from panelists? Okay, thank you.
Thank you.
And now we will shift to next speaker, Professor Paul Gardner. Please start sharing your screen.
Absolutely. Thank you very much. Thank you for the invitation, and thank you to Dr. Campero for letting me go ahead. Unfortunately, I have to have a Saturday day case that I need to take care of. So I'm going to be speaking, we're asked to talk about remarkable cases, and I kind of want to talk about some cases that have stood out to me as being both challenging as well as also cases that I think I learned something from. These are my disclosure, which are not really relevant for this talk. You saw some beautiful anatomy, as always, from Maria, and here we can see that area of the superior hypophyseal artery and what's called the carotid cave from a superior approach, and you can see how this area just deep to the optic nerve is really generally pretty invisible, so you can't really see it from a cranial perspective, but this is the view we get from below, so you can really see the origin of the superior hypophyseal artery, which often is just on the proximal side of the carotid artery, which makes these carotid cave aneurysms even sometimes hidden in the extradural space. It can be very difficult to tell, even with good imaging, whether or not they're extradural or not. So the dural rings play a huge role here. You can see a careful dissection of the dural rings as they come around the anterior clinoid to meet essentially at the diaphragma. And this is the area where these aneurysms can form. It can be tough to tell if they're purely extradural and in the cavernous sinus or not. Here is such an aneurysm that's coming off. It's a medial pointing superior hypophyseal type aneurysm. And here's a view of the angiogram. And again, even when you look at the relationship with the anterior clinoid, we can't really be sure whether or not this is intradural or not. So here's the clipping of that aneurysm done endonasally because it's medial. And so I feel like we felt as though we'd have better view of the distal dural rings and also, more importantly, perhaps better proximal control. Of course, we did a nasal septal flap. And here you can see the very wide sphenodotomy. And here's the sella right here in the middle. And then the paraclival carotid there is being cleared off. And the reason we've exposed that entire paraclival and cavernous carotid artery is to provide our proximal control. So here you can see opening the cavernous sinus all the way down to the paraclival, testing my temporary clip just to make sure that I have good proximal control, and then carefully dissecting distally, or drilling and exposing distally. So before I even expose that distal cavernous carotid artery, I wanted to have proximal control. I'm Dopplering. You can see the aneurysm here bulging at least partly into the sella. So here we're opening up to the where the dural rings come together. So here the dural rings are coming together, and then I'll open into the suprasellar space. So now I have my distal control on this. And understanding that anatomy that Dr. Perez-Celda just showed is really critical. I'm opening, making sure I'm above the ophthalmic artery, so opening in the mid or upper portion of the optic canal. And sure enough, here I start to see the aneurysm. Now I can't tell, there's a little bit perhaps of the neck of the aneurysm that's crossing the dural ring. And that becomes very obvious, unfortunately, as I cut the dural ring, because I end up rupturing the aneurysm, which is, of course, not what I wanted to do. I thought that the aneurysm was entirely within the cavernous sinus at this point, but obviously, as I cut that distal dural ring, there was a portion of it that had gone beyond the distal dural ring and had gone intradurally and into the subarachnoid space. So it's very difficult to tell. I had learned from previous aneurysms that if you don't open that dural ring, that you're not going to be able to get your clip across the aneurysm because the aneurysm is held there. So this was a real test to whether or not we could actually manage something like an intraop rupture here. So I'm sacrificing the superior hypophyseal in this case and trying to coagulate, but I can't quite get control because the injury is right at the neck of the aneurysm. Now I have great proximal and distal control. I have a cotinoid on here. So I'm just going to try to place a single straight clip across there. And, a couple lessons with this. Number one, I'm obviously frustrated with myself for having created this injury, but also worried now because, did I take the wrong approach for this? But I really feel like I have a good view of this. And now here I'm using a technique that's well described by Dan Barrow and others about using a little piece of cotton to simply pinch up against the wall of the injury. When the injury is right at the takeoff, you're basically making your clip flatter and you're compressing this piece of cotton against the aneurysm, and then we'll just a little bit of clip adjustment to make sure we get any bit of that aneurysm that extended off into the subarachnoid space. So here I'm placing my proximal clip now, so I can do a little bit of clip replacement. Now that I have control over it, I can place my proximal clip and do a little bit of adjustment of the clip and place this clip here, a curved clip, to make sure I pick up that portion of the neck of the aneurysms going intradurally. So very important to understand. And that's a great view you saw right there for a moment, where you can see how my clip stopped just short. And here's the distal dural ring, and there's aneurysm that's intradural. So one of the lessons here is it's very difficult to tell whether or not you're intradural or extradural with many of these aneurysms. And the other lesson is you really have to see those cuts on the dural ring and make sure that you can control the vessel before you ever attempt a surgery like this. Certainly, I would not propose that this is a common surgery to be done. We've maybe only done about 20 endonasal aneurysms. It's not a common thing to do, and that's only after significant experience with endonasal surgery. So here, just inspecting and then doing our reconstruction, which of course has to be a multi-layer reconstruction in order to make sure those clips don't get exposed, including nasal septal flap, which you see going up last here. Here's our intraoperative angiogram. Looks quite good, doesn't show any residual, and you can see the ophthalmic artery still filling on that lateral. Here's the post-op showing that clip in place. Now, a further area we can deal with those dural rings is actually to go on the inside of it and actually do what's called a full hemitransposition of the pituitary gland. Here's a case of a very significantly growing midbrain brainstem cavernous malformation. We can see the size of it. The patient's significantly symptomatic at this point with a partial third nerve palsy and some hemiparesis, and the cav mal just keeps progressing. So we did, and you can see here, the only place it comes to the surface is right anteriorly at the most anterior portion. So we did fiber tracking to see whether or not the motor tracts were separated by this cav mal. And sure enough, on high definition fiber tracking, you can see here's the lateral spinothalamic tracts. And then therefore we propose doing an endonasal corridor for this. Here's the area where we actually have access to this, just below the mammillary bodies. And I'll skip through the nasal stage, but of course, we do a nasal septal flap on the right side, a very wide sphenoidotomy, clear out the cellar and the tuberculum. And just understanding this paracavernous and paracellar anatomy really helps us to be able to understand how to access the area behind the cella where the midbrain sits, and occasional lesions like this, which are anatomically appropriate, might sit. The same sort of exposure as we had on that last case, where we have exposure of the paracellar cavernous carotid artery, and even a bit of the clivus. Remember, this is essentially a posterior fossa of access to the midbrain. So now we open, again, that right cavernous sinus. We're doing a hemi-transposition, so we push the gland over toward its left side, open up the cavernous sinus in a so-called interdural fashion, and then open into the suprasellar space. So here now we're cutting where that same area where the distal dural ring crosses the diaphragma. Here I'm actually cutting it right also at the where the stalk comes through, so I can mobilize the stalk. And this gives me great access to the posterior clinoid. There's no aneurysm here, so I don't have that same risk of rupturing the aneurysm, but I'm completing my posterior clinoidectomy. And now I have access directly through to the cav mal at the midbrain. So here we are dissecting now. You can see we're having to work next to and under the gland. And you can see I had to open up the lamina terminalis here. I'm sorry, open up the floor of the third, so to do a reverse third ventriculostomy, because there was a little bit of bulge of the third ventricle. And this gave me the ability now to visualize that hemosiderin-laden area right in the midbrain. I can see the perforators off of the basilar to be able to separate them and be able to access. And that right there, you can see the discoloration. I can visualize the perforators very well to make sure I've chosen an area that's clear of perforators, and then I can very carefully dissect into the midbrain and access the cavernous malformation. Here you see the relationship that we'd have plotted out relative to the various nuclei based on fiber tracking. And here's a nice little forceps dissection. So again, using microsurgical dissection in the same fashion, navigation to take me directly back onto the cavernous malformation. And then the remainder of this is standard microsurgical resection of the cav mal. We want to remove that fibrous capsule, not only drain the heme from it, but remove that fibrous capsule. Now you'll notice as we're doing this in a piecemeal fashion, and we're still getting a little bit of bleeding, so I have a feeling there's still some cav mal left behind, and we're not all the way back based on navigation. And again, the endoscope can be introduced all the way into the cav mal cavity, which really gives us a great ability to be able to dissect it free. Here's that piecemeal dissection. Again, checking with navigation. There you can see we're not quite to the back of the cavity. And of course, I can still see some cav mal there. Dissecting it free, carefully peeling it out. As usual, the corticectomy you make starts to slowly open itself, and there looks like we probably got the last final bit of the cav mal that we really wanted. A couple more pieces still in there. Not a small cav mal in this case. And here's our final defect, and we'll irrigate it out. You can see I'm protecting with a neuropathial place papaverin on the vasculature. I've managed to preserve all of those perforators. And then, of course, a multi-layer reconstruction. Place the lumbar drain, and her hemiparesis, as usual, patients get slightly worse. Now she's completely back to normal at this point, and you see a great resection with no evidence of any stroke in the postoperative period. Moving on to a different area for the last couple of cases. This is a 70-year-old woman who presented with a subarachnoid hemorrhage and what turned out to be a relatively distal pica aneurysm. So you see how distally this is almost at the vertebrobasilar junction. So it's very ventral. I have great proximal control from a far lateral approach. So I chose a far lateral approach, very standard approach. Here you can see the aneurysm. I've done an extradural dissection even of the vert to make sure I have control over it. Here we see 11, and I'm dissecting across the vert. And here's the aneurysm coming into view. I can see the aneurysm, but what I don't have is I don't have distal control. The lower cranial nerves are blocking my ability to have distal control of this aneurysm. So I can certainly place a clip, but I can't see the distal vertebral artery because it's diving directly away from me. So here I'm working between the lower cranial nerves, again, potentially at least causing an apraxia of those lower cranial nerves. I finally get a clip in place on this and start to, of course, get some bleeding from the aneurysm. There I'm dissecting the neck a little better. And as I place a clip that I'm finally happy with here, trying to leave the pica open, trying to visualize the pica origin right there. But I do an intraoperative angiogram and it looks like I've occluded the distal vert because I really can't see it. So now I try to reposition, and now I've got some pretty bad bleeding and I don't have good distal control again. I place my proximal clip, and you can see what a tight and narrow space this is. And this may be very uncomfortable because of the fact that I'm clipping between 9-10 and the 7-8 complex up above me. I have a very narrow window between very important structures. Finally, I get a reasonable clip in place. You can see there's still a little bit of residual, and I've partially occluded the pica. So multiple repositionings of clips. I don't have, again, great distal control, and I can't see the pica very well just because simply of the anatomy of how deep and ventral this aneurysm is. Eventually, able to get this under control, again, a fair amount of intraoperative rupture, but I didn't think that this was a lack of proper exposure. I had done the right exposure. I'd done a far lateral approach. I just didn't have a good view of what I needed to see. So I gave the patient adenosine, finally able to get a reasonable clip construct. You can see I've managed to leave the pica open in this case. Finally, and able to place the clip across. This patient postoperatively did have difficulties with swallowing, even needed a prolonged feeding tube before she recovered. So here we see our final view, and the vertebral artery is actually open and a reasonable result, although I'm not, the pica was really very diminutive and definitely was stenosed in this case. So I thought about this, and we've done the far medial approach as opposed to the far lateral approach for tumors like this very large chordoma. And this gives us the ability to have wide exposure all the way out to the jugular frame. And here you see some bleeding from the inferior petrosal sinus. And this is sort of the reverse. We're drilling out the medial jugular tubercle as opposed to the lateral jugular tubercle like we did from a far lateral approach. And so I understood this anatomy. I understood what we could see with it. Here we're drilling out the jugular tubercle, and I have my hypoglossal canals on either side. When I open the dura here, this is the view I've got. When I open the dura, I have a great view of the vertebro-basilar junction. I have good control. Here are my hypoglossal canals. I've got the vertebro-basilar junction. So I understood very well what kind of view I could get and what kind of control I could get with this. And so I had another aneurysm like this, and this was, again, a very ventral pica aneurysm. A woman presented with a ruptured aneurysm, a pica aneurysm, and the same story, a little bit younger patient, but a very ventral pica. So in this case, I wanted to try to do now a far medial approach. So here we're drilling out the foramen magnum. We've taken down what's called a rhinopharyngeal flap, where we take some of the basopharyngeal and nasopharyngeal tissue downward that will flap back up afterwards. It's a nice vascularized area. Do a complete clival removal. And now the trick to the far medial is to dissect out the area of the foramen lacerum. I've placed my flap up now on the sella so that I can drill out the clivus. Here's the paraclival carotid artery, and I'm drilling right next to foramen lacerum here. And that's the key to a far lateral, because that's what takes you in to the medial jugular tubercle, and it gives you a much wider clivectomy. So here's a very wide clivectomy. We've drilled out the jugular tubercle, just like the jugular tubercle from lateral gives you better access to the vert intradurally from an open far lateral approach. Drilling it out from an endonasal far medial approach gives you better access to the vertebral artery endonasally. It gets me that more lateral access. So now I can open the dura, and as opposed to with that lateral approach where I didn't feel like I had good proximal and distal control, here not only do I have good proximal and distal control, I'm placing a proximal clip. I'm testing my proximal clip placement. I can see the 6th nerve here coming off. There's not a single cranial nerve I'm having to work through here. So the lower cranial nerves, as they were in that other case, are on the deep side of the aneurysm. You can see them there. So I can avoid any manipulation of them. You can see how fragile this aneurysm is. Simply placing a clip across it starts to give me some bleeding from the aneurysm. Very similar to that last one, where it essentially is an extremely fragile aneurysm, and I'm stuck sort of having to try to reconstruct it in the setting of bleeding. So I place my temporary clip. Again, I have good proximal control, just as I did in the other case, but here I also have good distal control if I need it. So I do some clip manipulation, get it into a reasonable view. There's a little bit perhaps of residual left here, a little tit left. And I can see that. And I do indocyanine green endoscopy. And I can tell, unfortunately, my pica is occluded and I've left a small residual. So it's a good view here of how the cranial nerves are the lower cranial nerves completely blocking access from a lateral approach. So now I'm going to, again, place my clips and I'm going to trap it with a proximal and distal clip. Now I have complete control over this aneurysm. I don't have that seen as I did from a lateral approach where blood's welling out of the head at me. And I can carefully place my clip, leave the pica open, place a secondary clip on that small distal nubbin of aneurysm that's left. And then I can take a look again with indocyanine green, that little nubbin is gone. And if I look below, I'll see the pica. There's my pica, both Dopplering as well as filling very nicely. So I know I've managed to preserve this. I felt like I had much better control. And here's our final clip construct. And of course, a multi-layer reconstruction. In this case, fortunately, the clips are largely intradural with fascia, fat, and a flap. And here's our postoperative or intraoperative angiogram showing really a very satisfactory clipping. She ended up requiring a shunt, as many subarachnoid do, but had no neurologic deficit. So again, thank you for this invitation. And these are cases I've learned something from. I don't know that this is necessarily the right way to do these, but in my hands, understanding the anatomy and knowing a different way to come at some of these vascular lesions really can be very helpful. Thank you very much.
Thanks a lot, dear friend, for this excellent presentation. Is there any question from panelists? Okay, I think it was too clear enough to don't let to ask any question. Thank you, Gardner. Thank you, sir.
Thank you. Good to see you, Alvaro. Thank you.
Me too, thank you.
Thank you.
Trying to stop share if I can here. There we go.
Okay, and now we will shift to next speaker, Professor Campero. Please start sharing your screen.
Okay, could you see?
It's
Yes.
okay.
Perfect.
Okay, perfect. Okay, hello everyone. Thank you very much for the invitation, Same. And I'm going to show with you a case that we operated at the end of the last year. A woman, 34 years old, hairdresser and makeup artist, consulted by headache and neck pain, diplopia, mild right side hemiparesis, and paresthesis in the right side. And we can see that meningioma for the skull base. We can see in the axial view from below to up at the level of the spinal cord, and then at the level of the foramen magnum, and at the inferior portion of the CP angle, and at the level of the petroclival region, and also above with the compression of the mesencephalon. So we can say that this kind of meningioma is like three meningiomas: spinal cord meningioma, foramen magnum meningioma, and petroclival meningioma. So in this case, we decided to perform a 2-day surgery. The first day, an extradural stage, we performed a big approach with a pre-sigmoid approach. Now we are in the semi-sitting position. We are drilling the mastoid. Now we are coagulating the pre-sigmoid dura. At the end, this is the approach that we performed in the first day, with the exposure of the temporal dura, pre-sigmoid dura, retrosigmoid dura, and also at the level of spinal dura, and also we perform in a far lateral approach. So subtemporal, pre-sigmoid, retrosigmoid, and far lateral approach. And the second day, we performed the intradural stage, also in a semi-sitting position. So we started to operate from below to up. This is the initial view of the far lateral approach in the left side, in the semi-sitting position. So we can see the C1, the tumor, and the spinal cord. and we start to perform the dissection. This is the 11th cranial nerve. So we start to see the different things in that region. So we can see here C2 and also again the 11th cranial nerve. So we start with the ultrasonic aspiration to perform the debulking of the tumor and to use the arachnoid dissection. So we are going from below to up. So we mobilize a little bit the tonsils in order to see a little bit better the foramen magnum. So now we are working lateral to the 11th cranial nerve. So we can see now the vertebral artery and the dura of the inferior portion of the clivus and the foramen magnum. So now we are going up, but this is the last view of the far lateral view. This is the lower cranial nerve. So then we change to the retrosigmoid approach view. So we can see here the tumor. We cannot see at the beginning the 7th and 8th cranial nerve or the 5th cranial nerve. So start to perform the debulking with the ultrasonic aspiration. Now we start to see the 7th and 8th cranial nerve, tumor above and tumor below. This is the lower cranial nerve. So we work with the ultrasonic aspiration below and above the 7th and 8th cranial nerve. So this is the superior petrosal vein that we try to not to damage any vein in the posterior fossa. Now we are working between the superior petrosal vein and the 7th and 8th cranial nerve. And then this is the final view of the retrosigmoid approach. Then we went to the presigmoid view. So this is the subtemporal, the vein of Labé. So we are mobilizing up the inferior portion of the temporal lobe. This is the tentorium. We are cutting the tentorium in order to have a good exposition of subtemporal and presigmoid view. So this is the 5th cranial nerve, cerebellum, tumor in that portion. Now we start to see the 4th cranial nerve, the lateral portion of the mesencephalon. So this is tumor, cerebellum, and so on. So we are working with the ultrasonic aspiration. Now the 4th cranial nerve is free. And this is a view with tumor medially to the 5th cranial nerve. Now we can see the basilar artery medial to the 5th cranial nerve, yet some tumor in front of the basilar artery. Now we are working with the presigmoid view, but between the 5th and the 7th and 8th cranial nerve. And now we can see a good windows between the 5th and 7th and 8th cranial nerve. Now this is the dura of the clivus. We can see now the 6th cranial nerve that sometimes is difficult to recognize and to preserve, but in this case we can see well the 6th cranial nerve and the complete resection of the portion of the tumor in front of the brain stem. And we can see the post-op CT scan with the big drilling of the mastoid, and we can see the pre and post-op MRI with the decompression of the brain stem and the upper portion of the spinal cord, and also in the coronal view. This is fat in order to avoid the CSF leak, and we can see also the axial pre and post-op MRI in the inferior portion, in the same at the level of the CP angle, a little bit up, and the decompression of the inferior portion of the mesencephalon and superior portion of the pons and in the upper portion. Of course, some kind of tumor that it's keep with the patient in order to avoid the damage of the cranial nerves. The post-op was very hard. The patient was in the ICU many days. She performed a pneumonia, but after the day that she was discharged, she sent this video because she liked very much to dance. And this is now 4 months later of the surgery. She is working now. She is dancing because she liked to do that, and she is performing a normal life. So our philosophy with that kind of tumor, probably it's one of the most difficult surgery, not just in neurosurgery, but in medicine. It is a very complex, not just surgery, but also a post-op. So we have to be prepared, not just for the surgery, but also for the post-op. We have to go to the surgery with the idea of solve the problem, to try to remove the majority of the tumor, and if it is possible, all the tumor. And we are going to dedicate that 2 days of surgery exclusively for our patient. Thank you very much for your attention.
Thanks a lot, dear friend, for excellent presentation and interesting case that you shared with us. My question to you about devascularization. As we know, in meningioma, one of the most important steps is devascularization. From your pre-operative imaging, what was the main fatal arising from? And have you interested in blocking it as fast as you can, or what was your strategy?
Yes, usually we try to use as much as possible the extradural stage of the surgery, but in my opinion, in that such big tumor, it is difficult because it has many different meningeal vascularization from the inferior clivus, middle clivus, superior clivus, and petroclival region, and so on. But I think with the extradural stage, when as much as possible, you have to drill the bone and to coagulate the dura extradural. At least I think that can help a little bit with the vascularization of the tumor.
Okay, thank you. Is there any question from panelists? Thanks a lot, dear Alvaro, for this excellent presentation, and nice to see you always. Thank you.
Thank you, my friend.
Thank you. John, now we will get to the end of our day. It was a great pleasure for me to join our dear friends and colleagues from every part of the world that we have learned many lessons today, starting from anatomy, pre-operative imaging, intraoperative dealing with most difficult cases in the world, and we have to learn and to learn and to learn. Thank you for joining us today, and I hope we will see you so soon. Thank you.
Yes,
John.
yes, Sam, thank you very much to all the participants and giving your free time for neurosurgery education. And I'd like to especially thank Sam for putting this all together. It's a lot of work. You did a great job. Thanks a lot, Sam.
See you.
See you next time.
See you. Thank you.
That went great, Sam.
It was more than great.
Yeah, it's great,
the
man.
content,
Great.
educational content today was very superb. We didn't experience such educational programs every day. I think we have done a great job.
Well, that was good discuss. I'm not a neurosurgeon, but I could see the discussions back and forth.
Yeah,
And I know that because the residents were remarking in the chat that it was like being at a master class. You know, all these masters from all over the place. Of course, they're very quiet, like most residents are, but that's okay. But I think they really appreciate it, seeing the discussion, seeing these people, you know, go back and forth.
Thanks a lot for your effort, John.
Yeah, okay, great. Okay, Sam, I guess we'll talk about ideas for, and we'll see, well, you know, we'll talk later about that stuff.
Okay, thank you. See you.
Okay, thanks, everybody.
See you.
Hey, is Roberto still there? Roberto, I don't know if he left. And Alvaro, I wonder if I have an operation, Sam, I'll be able to dance like that. Alvaro?
Yes. Hello, John.
Yeah.
How are you?
Hey, if I have an operation, can I dance like that?
Yes. Thank you.
Okay, thanks, everybody. Bye-bye.
Bye-bye.